Services Administration, as well as the chair of the commission this year. We have a jam-packed agenda, so we'll go ahead and dive right in. Before we do that, we have a little bit of business to take care of. So, did all the members get a chance to review the minutes? Is there any discussion on the minutes? Can I get a motion to approve?
Motion to approve the minutes from the previous meeting.
I'll make a second.
All right, all in favor?
Aye.
All right, motion passes. So that part's taken care of. So before we jump into the speakers, we have some wonderful speakers lined up. I wanted to say a couple things. I wanted to first thank a bunch of people. We probably could have very easily hosted this meeting at the government center, and it would have been way easier. But there's, I think, a lot of value in getting out in the community, because this is not the state of Indiana's commission. This is the commission for the people of the state of Indiana and the community and the people that we serve. And so thank you a lot, in particular to Julie in the corner there. Hey, Julie, wave, for her logistical help, and Kate, who's sitting at the table with us and hates the spotlight. But she will be speaking, so we'll see how that goes. She's going to be great. But thank you so much for your work on this. And then our partners, the AARP, Jason in particular, and Amber, thank you so much for all your help getting this going. And then I did want to quickly address kind of the elephant in the room. Situation has changed a little bit, I think, since the last time we met. And I've had several questions asked to me about, what impact potentially the Medicaid forecast situation could have on our work. And I mean, the answer is we don't know. But I just wanted to sort of address it and sort of say that, like, what that means for me in particular is that we need to double down on being kind of more targeted, more specific, and really thoughtful about the way we present our ultimate recommendations. Because the truth is, if we end up recommending something like the state just spend a bunch of money on these 10 things, it's probably going to be a tougher conversation now than it would have been a few months ago. So all that to say, it shouldn't change our work. It shouldn't change our focus on recommending and doing what's best for the people of our state. But it's just something I think we have to acknowledge and just kind of roll with, right? And we'll see how it evolves. But I've been asked that by several people, so I thought I'd just go ahead and address it directly. So with that, we have a wonderful lineup of speakers. Thank you so much to the University of Indianapolis in particular for their hosting here. And I will not try to introduce these people because I don't really know anything about them. So I'll let them introduce themselves, other than that they're, amazing experts and they're going to give us some wonderful information. So, but first up, we have Ellen Burton and Amanda Wolf. So if you can come up here and go ahead and introduce yourself and let us know kind of who you are. And thank you so much for joining us.
Thank you, Jay. Appreciate it. Good morning, everyone. My name is Ellen Burton. I am the Executive Director here at the University of Indianapolis Center for Aging and Community. We are very glad that you all could be here with us on campus today. As your host for this morning's activities and discussion, just a couple of quick logistical things for since we will be here for a couple of hours. The facilities are basically out the door and back around. There is a coffee shop if you find yourself in need of refreshments, just that way out the door. I think you all have figured out the mics already. There's a button, push to talk. So just be sure if you don't want to have a hot mic in front of you, you push the button again to turn it off. And then lastly, for everyone who is here, it looks like several folks have gotten connected to the Wi-Fi, but there is a guest Wi-Fi that should get you access without a password. Okay. So with that taken care of, my name is Ellen Burton. Unfortunately, my colleague Amanda Wolf could not be here this morning. So it is my pleasure to talk with you about why we need to really think about older adults when the commission is considering its recommendations. And many thanks to all of you for bringing this conversation to us. We're very excited to be a part of it. So let's see. There we go. All right. So as we think about this, and I will admit, talking about older adults is perhaps my favorite topic. So bear with me if I get a little excited. But I think that it's really important to give you all a little bit of a sense of what is the older adult picture in Indiana these days? As the commission thinks about and considers recommendations across all of the needs and the desires of the state, we have to think about all of our different populations. And often older adults, we think, oh yeah, okay, so there's some older adults and that's okay, and there's not really a big group of people. But in fact, already nearly a quarter of all Hoosiers are 60 plus. So we are already hitting a mark where a significant portion of our state's population is considered an older adult. And we have to think about the fact that based on a survey that was run last year, 82% of folks, older adults, and that's starting at 55 based on the survey parameters, they plan to retire in their community. So they're going to stay. We've already got a quarter of our population who are older. They're not planning to go anywhere. Folks are planning to age here in Indiana. So we really want to be mindful of that. And what that is leading to is that by 2040, the projections are that we will have more than 1.6 million older adults here in Indiana. So, and that's a significant portion of our population. So really a much larger and growing body. Certainly in central Indiana, older adults are the fastest growing demographic that we have, and that is starting to be replicated across the state. There are projections that by next year, even 62 out of our 92 counties will have 1 in 5 residents will be older adults. So it really is a significant portion of our population. And I know you all have probably seen the population pyramids that we have up there and the way that it is starting to go from a pyramid to more of just a straight up and down rectangle. Again, so giving that sense of this is a significant portion of our population that we want to make sure we are considering as we think about all of the needs for behavioral health supports. Okay. So I know that there are lots of wonderful subject matter experts here today who will talk through in oh, there we go. Found a dead spot for everybody who comes up here next. Who will talk in much more detail and with much more knowledge in these subjects than I am able to present to you today in just a few minutes. But these are some of the key crossovers between older adults and behavioral and mental health that we need to think about. Excuse me. So certainly substance use disorder is a growing and persistent challenge or consideration that we need to keep in mind. We are seeing that deaths due to overdose are increasing for older adults. The rates of suicide for older adult, particularly older adult men, that has increased significantly over the last several years. And what we are finding, this was actually a really interesting finding from a colleague at SAMHSA who presented at the IDOH Long-Term Care Leadership Conference recently. But the baby boomer generation, which is the bulk of our older adults and continuing to be the bulk of our older adults currently, they have the highest rate of illicit drug use across all of the different population demographics. So I'm seeing a couple of furrowed brows. I can give you that source if you want that information. There's references in the slides, but certainly that is something to think about. So the other piece another big crossover here would be depression and anxiety. We are seeing that nearly 44% of older adults are reporting that they feel depressed, that they feel sad. Certainly COVID and the shifts in the increase in social isolation, got that one out, have exacerbated that issue. So that is, again, another piece to think about. As I mentioned, the suicides for older adult men, they are rising, and we are really need to think about that some of these root causes for older adults may be different than what we talk about for middle-aged adults or young adults or children. If you think about the natural progression of aging, older adults are experiencing loss of their friends, loss of their families, loss of their spouses at a higher rate than we would typically see at younger ages. And this could all contribute, but it's a unique piece. So again, a thought that we need to have some consideration to the unique situations and the unique root causes. Even though some of the challenges may be the same, the root causes are different. So that is always an important piece to think about. Now, I don't want to say that this is all doom and gloom for older adults. But there is, because you have to think about, there is that wonderful quote from Mark Twain about complaint about getting old. It is a privilege denied to many, right? And what we are seeing is that this is a privilege that is now being denied to fewer people because of advances that we have made in medical technology, in understanding of health, physical and mental wellness, in social supports, in the way that we are connected and in how community plays a piece. People are living longer, just in general, which is great, but also folks who traditionally had perhaps a diagnosis or a condition that would have led to a significantly shortened lifespan. We are finding ways and making sure that those folks can also have the privilege of living to old age. So that's a really exciting time to be in, to be able to see this progress and this growth that we're making. But it does come along with the fact that we need to be thinking about some of those things. As we are thinking about behavioral health challenges, we have to think about, now that folks are getting older, there may be co-occurring physical challenges, and we need to think about those. And I found an interesting statistic too, that more than 40% of people with schizophrenia are over 55 years old. So we're seeing folks who are aging, and there's this notable confluence of that we hadn't seen before. So always good to think about as our population shifts. The other piece that I wanted to mention, and I know we have some wonderful subject matter experts who will talk more about this today, but we have to consider the impact of dementia. So now I'm not saying that this is a mental health problem. I know that there are lots of folks in debate around how you classify dementia, but it is a co-occurring condition. And we are seeing that there are almost 6 million people in the US who currently have dementia, and that is estimated to double in the next 25 years, give or take. So as we are seeing this, and as we consider behavioral health and mental health needs, we have to think about the fact that if we're talking about older adults, there is a likelihood that there will be a co-occurring diagnosis of dementia. And that is a piece that we need to better understand and have the resources to support. Okay. So just a quick thought about, so how are we going to address this? One of the pieces that we have noted, the CAC has had the privilege to do a lot of stakeholder engagement work in collaboration with and on behalf of the state. And so we get wonderful opportunities to go around the state and meet with folks and talk with older adults and talk with their colleagues and their family and their partners to say, what's going on? What are the challenges that you're facing? How can we bring this back to the state, to the Division of Aging, so that they can make sure programs are being responsive and addressing your needs. And the biggest thing that we're hearing is access to services is a challenge. And this is all across the state. To varying degrees, there is certainly disparate access across the different regions of the state, but pretty much anywhere you can say, man, it's kind of hard to find someone, to find a provider, to be able to find a provider that I can afford, to find a provider that has the specialty that I need to be able to think about this, to find a provider who has the specialty that I need and also understands older adults. So it's a complex, layered piece to the access question. And you can see there's in this community survey of older adults, the responses are, that's the graph there, that only about a third of folks, of the respondents there, are saying that their access to affordable mental health care has been a good experience. So, or that it is good access, pardon me. That's not a quality statement, that's an access statement. So that has been a challenge and one for the consideration of the group. Okay, and I think I am running short on time, so I will just bring up one last piece. It is very hard to talk about older adults and what they need and how we support them well without talking about their caregivers. So there are a significant number of older adults who have an informal support network. Often that is a relative. It is not uncommon for that to be a spouse who is also an older adult, or an adult child who may not be an older adult yet, but hopefully will be. So when we think about the caregivers, there is also noted studies. This this graphic in particular is from A Place for Mom and their website and their facts about caregivers, but our colleagues at AARP have done significant work and have resources about caregivers and the impact of caregiving. And we have heard, especially with the national attention on this issue, that there is a notable physical and mental impact on the caregiver themselves due to the act of caregiving. Now, most would say, I would never trade it. This is one, I want to take care of my loved one. But we do need to think about the fact that not just the older adults in question have needs and need supports, but their caregivers do as well. This quote that I have on the slide here, I think is particularly impactful. In one of our stakeholder engagement opportunities, I had the privilege to have some one-on-one conversations with folks who were in the midst, I mean, they were in the thick of caregiving for their parent. And this particular caregiver, she had just sort of come through to the other side of the hill of, there's been a change of condition, there's been an event, we have to figure out what to do, we're trying to figure out where dad's gonna go. We finally got him settled and feeling okay, and I'm feeling okay about it now, but that gives me the space to reflect on how hard this was and how much of an impact it had on my mental health and quality of life as well. So I just wanted to bring that piece up as part of our conversation, because it is certainly a big piece of this puzzle that we're all trying to figure out, and one that we want to make sure is part of the conversation. All right. I think that is just about the end of my time, and I know we have lots of other folks to hear from. So if there are any questions, I'm happy to take those, or we will certainly be around and happy to answer at any time.
Yeah, so we actually have some time. So if there's any questions, we can take those now.
Ellen, so you're hitting on the care, like, can we talk a little bit more about the caregiver piece of this? Because, as you mentioned, so the numbers for this in unpaid care in Indiana just alone is over $10 billion that family caregivers provide with regards to care, and they're literally holding up the system in a lot of ways. So is there, based off of the research and the things that you've seen and the people that you've talked to, what is it that maybe caregivers would need that the state could potentially put forward from a policy perspective to, help them out in the work that they're doing? Because as we said, the number of unpaid hours is 740 million or something along those lines, and there's hundreds of thousands of family caregivers in our state that are providing this care. So I guess, have you had those conversations? Have folks said some things about what they may want or what they may need that could just help them do what they're doing a little bit easier?
Yeah, that is a great question. Thank you for that. We have had those conversations, and it's been really fascinating. And one of the things that I personally have been having those conversations for the last decade in a variety of different experiences and opportunities. And one of the things that particularly pops up on a regular basis is caregivers don't know what's out there. They don't know what services are available. They don't know where to go. If you ask, and I will tell you personally, my own parents, when my grandparents started aging, they were at a loss until I finally sat them down and said, Mom, you have heard me talk about the area agencies on aging. Every conversation we have had, please let me help you. But what that personal experience is very much a mirror of the experiences we're hearing from, is that people don't look for the information until they need it. So we have a particular challenge, because I know that there are wonderful communication initiatives out there. There is the InConnect Alliance that has been a piece of the Division of Aging for a long time. There is the No Wrong Door Initiative, which is a cross-sector, the Multi-Sector Plan on Aging, which is now a government or a governor's priority, is really geared at making sure that we are interconnected enough so that once somebody touches this system at any point, we can get them where they need to be. But caregivers tend to not listen to that information until it becomes particularly salient for them, until their personal need is great. So we have the challenge of trying to figure out, how do we take our ongoing communication initiatives and education initiatives and make them so that they are so available that people do remember, oh, I do remember where I can go. I know I can call AARP. They've got this great link on their website. I know I can go to the state website and Google mental health, and it'll take me to DMHA, and I can get some information there. So I think that's been a key piece that we have seen, is that, and it feels to us like maybe we're not being successful. And I don't think that that's the case. I think it's that every couple of years you get a new cohort of people who now have this challenge. So I think one of the things we need to think about is, how do we, let's be fair, aging is not exactly like the razzle dazzle that a lot of people want to see. So how do we get people to pay attention? We're here, we're ready to help, we want to support. How do we make sure that people know where to get to the whole network of supports? And then once they touch any one of those pieces, how do they get to where they need to be? So that's a lot of what we're hearing in terms of the stakeholder feedback.
Thank you.
And actually, if I'll add one more piece. One key piece to that is getting the information into the hands and the brains and the leaflets of primary care, because that's where people go. They go to their doctor first. And if their doctor doesn't know to send them to their AAA or the Division of Aging or the community mental health centers or any of the variety of resources, then they sort of stop. So I think that's a key piece too, making sure the primary care has the information and knows when to pass that along.
I had one just sort of question, kind of comment. And so I'm so glad you mentioned messaging, because my staff will tell you I'm obsessed with messaging and how we message things, and we're really bad at it generally. And I think we're getting a little better. But in terms of framing this for, I think, the things that move the needle here in the state of Indiana, like, are you aware of any research or studies on like the economic impact of the amount of time people spend? Because these are people generally in working age folks, and if you're spending 720 million hours of taking care of mom and dad, and I'm starting to get in that boat too myself personally, and so I think I'm starting to be aware of it in a way that I wasn't before. How is that impacting our ability to sort of compete economically?
Yeah, that's a great question and a really good consideration. And I just read a study that had some of those statistics this week, and I cannot pull them out of my head, but I am happy to find the specific numbers, although I know that AARP has done a lot of work on this and may have some of those specific numbers. But you are absolutely right that the economic impact of caregiving is significant on two sides of the coin. So caregivers, informal, unpaid caregivers, provide billions of dollars of essentially free labor to support the system. Which makes you think about then paid caregivers and how much they provide for this same kind of support. The other piece of that, like you've said, is that it does take a toll on the individual, and then there is lost productivity when the caregiver is not their best in their employment environment, in their day-to-day environment. And it does lead to, there are studies that show that it does lead to decreased productivity. We can tell you, actually, several of my colleagues who are here today work with our caregiver resource group here on campus. Excuse me. And we provide this service because we know that our colleagues here on campus, many of them are also in the situation of trying to provide care for a loved one or a family member or a friend. And it does have a significant impact. And there are lots of stories about, man, I can't concentrate today because I have so much going on with my care, my caregiving responsibilities. So you're right. It is a significant economic impact due to lost productivity, because they're trying to figure out, what am I going to do with mom, with dad? How am I going to make sure that they're okay? So I can dig into that information and provide it
Oh,
later, but I
thank
don't
you.
have
That's wonderful. And
numbers.
just for the commission in general, I mean, I know this is sort of our first substantive meeting. Like, we've had one intro meeting in this, but I think we need to start thinking about themes that emerge kind of across populations. And I think, Dr. Yoder and David will tell you a lot of these themes very much emerge with children, for example, children with mental illness. And so, like, things like cognitive load, reduced productivity, reduced ability to kind of like flourish because of kind of the inadequacies of the system. Like, maybe not, that's not as important maybe from a policy prescription standpoint, but it's really important from a policy framing standpoint about like why we need to do this. And so just as we're thinking about these conversations as a commission, I think we need to like kind of double down on that as like, look, this is an imperative for a flourishing society to have sort of a baseline level of support across the board for these folks. That's kind of one. And number two, and Dr. Yoder, we'll talk about this a lot more. Primary care, I think across the board is probably the single best entry point for a lot of these things. So.
Just to build on what Jay's saying, I was curious, are there any states where employers are involved in this conversation? And when, to make the analogy that Jay was talking about, a lot of families are affected by childcare issues, and employers do step up and they are part of the discussion and they come up with benefits. And I just wonder, has that ever happened as it relates to aging population, and are there models that we could replicate? And then to Jay's point about messaging, some of the stakeholder groups that we might want to pull in and be like the chamber or some other business groups.
Yeah, that's a great question. Always good to be able to pull from others who have been through it to understand what's working. Then maybe we can avoid some of the hurdles that the first group through maybe hit. There are a couple of different states and examples, and would be happy to do a little more research on that for you. But a couple that come to mind, I know there are some initiatives in New York to try to figure out how to support people who are providing care for older adults. In the state of Washington, they are just sort of about a year or so into the implementation of a state, I have to think about this exactly, and if anybody else has, well, there is a state-sponsored, funded long-term care insurance. So it is a way to provide a more equitable access to long-term services and supports. Relatively new towards implementation. I think they're still working on a couple of the bugs there, but it's something certainly to keep an eye on to see how it works and what are the best practices and what are some of the challenges that they're bumping into. So yeah, there's a couple of different states that are trying to tackle this.
And sorry, if it's okay if I jump in here one more time. So kind of what everybody's saying with regards to the economic impact. I know that AARP has some information with regards to the older workforce and the economic impact they have as well. But I know that there's also, we have information, I think, along the lines of the out-of-pocket costs that unpaid family caregivers are paying on a yearly basis. A lot of times it's over in excess of $5,000 a year. And then often we are much along the lines of what we were talking about with regards to children. You're having older adults that they wouldn't consider themselves older, and they're not. But they're taking care of an aging family member that is being forced to leave the workforce. And that has that economic impact as well, because they are having to take care of not only their family, but also now an aging parent or something along those lines. So I think and I can dig into more to that because I think we have some of those numbers that I can provide to the rest of the commission members. But that is an economic impact that we're talking about, is because there's a lot of folks that are being forced to leave the workforce because they are caring for an older parent or an older loved one.
Jason, kind of along those lines, sort of, but we see a lot in child welfare is a lot of grandparents taking care of their grandchildren because the generation in between had challenges and wasn't able to meet the needs of their own children. How do we support those folks is critical, that they have their needs met to be able to take care of these children that they've kind of been forced with that responsibility. So keeping that in mind as well is critical from a child welfare standpoint.
To add on to that, we have a colleague here at the University of Indianapolis who is looking into kinship care and as it relates to older adults. What she has found, and so kinship care, for those of you who may not be familiar, is sort of an informal caregiving agreement for if children can't stay in their home, a family member typically will say, well, it's okay, they can come stay with me. I'll take care of them till mom and or dad, get back on their feet and are able to take them. It's not a formal relationship like foster care is. It tends to be more informal, which also means it's not always documented as much. But Indiana tends to have, by national averages, higher rates of kinship care, is my understanding.
So yes, that's exactly right, Ellen. I mean, so formal arrangements are very common with kids who are involved with the Department of Child Services. We have about half of our kids upon removal get placed with relatives. And then often families are complicated, and a lot of times they do their own arrangements that we're not at all involved in. But again, it's grandparents taking care of grandchildren, or aunts or uncles, whoever taking care of relatives, and being mindful of their needs is really important for this conversation.
All right. Well, Ellen, thank you so much. That was I think a fantastic kind of framing of the issue. And I think that one thing just to talk to people in the audience and watching and commission members is, these conversations, I think we'll see, will necessarily start to stray pretty quickly from behavioral health, because the truth is that like life impacts behavioral health and mental health and vice versa so much. And so I think that that's totally like good. And I think we should continue to have those kind of broad ranging conversations. I think our challenge will be when it comes time to make recommendations and write a report, how do we address all of these things without trying to be like all things to all people, right? And so, there's something to keep in mind as we move forward. Look forward to following back up with you and maybe doing some debrief and sending some more resources out to commission members. But again, thank you so much for hosting us and for your presentation.
Yeah, thank you. Glad to have you all here. Looking forward to the rest of the conversation.
Thank you. All right. How's everybody doing break wise? Good. All right. Next up, we have Leslie Olick. And Leslie, if you want to jump up there and introduce yourself, and thank you.
Hi. Thank you. Getting a little bit of technological information here. I'm Leslie Olick. Excuse me. I'm a psychiatric clinical nurse specialist and a psychiatric mental health nurse practitioner, as well as a licensed marriage and family therapist. A member of a fellow of the American Academy of Nursing. And some of you are familiar. Good to see some of your faces. And Ellen, I used to work with your predecessor, Ellen Miller. When I taught here and I was active in the Center for Community as well as the Center for Aging. So I'm kind of a wanderer, so I'm going to attempt to pull this out and hopefully it'll stay engaged. Excuse me. I really like what you said, Ellen. Can y'all hear me okay? All right. And I'm very, very happy for this framework to put things in. We need to help older adults more in Indiana, as we know, and that's why we're here. And so I'm representing the Coalition of Advanced Practice Nurses today of Indiana. Okay. A lot of things that people don't know about nurses include that we APRNs have graduate degrees in psych mental health advanced practice. What I'm finding is that a lot of my family practice nurse colleagues are getting postgraduate certifications in psych mental health. Why? Because many of them are saying 30 to 50% of their clientele coming through have mental health issues. Some of my women's health practitioner friends say up to 75% of the people they see, which include older adults, are talking about mental health issues. We have 2 years of graduate studies after our 4-year of clinicals and didactic as an RN in general. And in Indiana, we've done studies that show that RNs becoming APRNs have 6 or more years working as RNs. So they're typically not babies coming out of their RN practices into APRN practices. Psych mental health APRNs not only have the advanced psychopharmacology, but we have advanced psychopharmacology, as well as psychotherapy courses. As a clinical nurse specialist, I had more emphasis on the psychotherapy, and nurse practitioners today do have psychotherapy included. So in talking about access, psych mental health graduate students are increasing in numbers exponentially. And as I said, some of the reasons are because they've been out there practicing as family nurse practitioners. And as family nurse practitioners, they're also having a large population of older adults, right? Because you can't be in a family practice and not see older adults. So they want to learn more about psych, which those of us in psych are really happy about. Nurses are the second largest group of behavioral care providers. I don't know if you all knew that, but we are second only to the numbers of social workers. We know that the number of trained psychiatrists is declining, and the Bowen Center in Indiana, which you're all probably familiar with, report from 2020, 661 respondents reported practicing in Indiana, and 339 APRNs responded to the survey. We know we have over 10 to 12,000 APRNs in Indiana at this point, more on the rise. So the good news is that psych mental health nurses practice in federally qualified health centers. So there is some integration of practice between family practice and psych mental health, which we've been hoping for a number of years. That is where that's where it's at, so to speak. Family nurse practitioners and family practice physicians sometimes don't know what to do with a person with mental health issues. They have a tight schedule. They need to keep moving on. So they need people to refer to that know something about mental health. We work in outpatient offices. Some are physician-owned. Some are system-owned. The large university systems, the large hospital systems in Indiana, as you know, often have behavioral health sections. And inpatient settings, in many roles, we also are educators, and I'll talk about that a little later. Anecdotally, my MP colleagues say 20 to 50% of the people they see, up to 75% of the people they see have mental health issues. A recent Journal of the American Medical Association article stated that from 2006 to 2018, primary care physicians managed 50% more mental health concerns in their practices. And we can all see that, as you know, because as Ellen was saying, the boomers are on the rise. And as you look at the societal changes that have occurred over a boomer's life, it's not really surprising that with what happened in the 60s, 70s, and early 80s, there's more substance use issues. We know from several sources that older adults are presenting with more substance use issues, which is what Ellen talked about. In 2020, the National Alliance for Mental Illness found that behavioral health office visits are over 5 times more likely to be out of network than a primary care physician, despite the federal laws for mental health parity, which are still coming short. Depending on who you read, the WHO, the World Health Organization, states that at least 14% of older adults have some form of mental illness. And if you read the CDC, they say 20%. So I think it's closer to 20% personally. And I think that in our offices and in our facilities, we see even more than that. An estimated 45% of psychiatrists and 30% of psychologists do not accept any form of insurance. And many offices, even the university or systems supported offices, are very selective about how many Medicaid patients they take. They'll take Medicare because it's a pretty sure payment. And let's face it, psych is not a moneymaker for most systems, which is a problem for all people, including older adults. And then Medicare, not so much. They'll take it, they'll say they take it, but they're very selective about how many Medicaid patients they will take. SAMHSA reports the need for more than 500,000 additional psych mental health nurses to reach merely adequate access to mental health and substance use disorder. And I'm a past president of the American Psychiatric Nurses Association, and I've been appalled at some of these numbers as we talk about these. The National Academy of Medicine in the Future of Nursing 2020 to 2030 states that lifting the barriers to practice, allowing advanced practice RNs to practice to the full extent of their education and training, will increase the types and amount of high quality health care services that can be provided to those with complex health social needs. I think what is concerning to some people about lifting a barrier to practice, such as the mandated collaborative agreement that we have in Indiana, is thinking that the nurses are just going to be out there running amok And nurses are trained and educated to work with others. Nurses typically, and I can't speak for all nurses because I'm sure any professional cannot speak for every professional, but most nurses know their scope and know their knowledge base. My family nurse practitioners love to refer to me. They know that's not their area. My women's health specialty people love to refer to me and to my colleagues because mental health is not their specialty. We know that older adults have very complex needs. We know that an older adult doesn't typically present anywhere without 1, 2, maybe 3 or more issues that are going on. It could be chronic pain. It could be a chronic disease to manage like diabetes. It could be a chronic disease to mention like osteoarthritis that pops up in different places, who knows when. And it could be that there's some depression. And we know that with chronic illnesses, that depression and anxiety are much more prone to occur to older adults. And we know that family practitioners and primary care practitioners try to do the best they can. And at some point, it just gets beyond what they can do and what they have time for. But we also know that mostly people present to those primary care providers, right? Try to talk somebody to going into a mental health clinic, especially in older adults, like, oh, that's not the problem. No, it's my feet. My feet are really the problem. My feet, and oh, I just feel so tired all the time. And so it's sometimes difficult to get older adults as well as other people to first present at a mental health clinic. According to the Kaiser Foundation in 2021, Indiana has 152 to 252, there was a category, of mental health professional shortage areas. We know that there are maybe 4 counties in Indiana that aren't listed as mental health shortage areas. I could be wrong. Maybe there's 6, maybe there's 3, but something like that. And this can be verified with HRSA data, which definitely needs to be updated, but I don't think it's going to be a whole lot better. We know from several sources that older adults are presenting with more substance use issues. A recent JAMA article stated, oh, I already said that. How did I get there? Okay, so have I got stories for you? I've got a career full of stories about the older adults that I've enjoyed taking care of. Most recently, I had at least one older adult couple come in. The husband's taking care of the wife who has schizophrenia, which as we know is a long-term chronic disorder, and needed her medications changed. And it was a struggle for them to get there. One time they were in charge of the 2-year-old toddler that was with them who was running amok through the whole session. We still managed to get things done. But these are the kinds of things they're looking at. It could have been a teenager. The teenager could have been fine. But they were charged with watching this toddler. So they're facing a lot of different things. They were lucky. They had access. They could get themselves to the clinic where I was working. But many don't. Again, struggles to get to clinics. When I worked in places that took more Medicaid, I had patients that would come. They would want to see their primary care person and they'd want to see their mental health person. Unfortunately, I think it was probably a coding concern, but it was widespread in the system. The patient had to take 2 buses to get to me. This is not an unusual story. This is an older adult taking 2 buses to get to the clinic where both providers were located. If they saw me first, it turned out Medicare, Medicaid waiver even wouldn't pay for the second visit. Now, it was unclear whether that was a coding problem because I talked to some of the physicians that were related to Medicare payments, and they said, we think that's a coding issue. But what I'm finding when I presented that to some of the administrative people, they didn't believe that it was a coding issue. They just said, well, that patient will have to come back. We need to insist that the coding is correct so that our patients don't have to jump through more hoops to get the care that they need. Lack of access. We know that. We've talked about that. I think we need to seriously look at the nurses that are out there ready to give access, the advanced practice nurses, as well as the RNs that are working in inpatient units, but can work in other places. Occupational therapy. Do we think that there are no mental health issues showing up at occupational therapy? I don't think so. So I think we need to look at some of that. Okay, when I was working here at the University of Indianapolis, I was teaching undergraduate students at that time. And my undergraduate students were not fond of going into their psych mental health program, the part of the curriculum that involved that. Part of that is stigma, which is something we definitely have to work with. My physician colleagues say it's not uncommon to see that among medical personnel as well. But so I thought, you know what? These students only know that they can take care of people in long-term facilities. They didn't think that would necessarily look like fun, especially compared to cardiac care and neonatology and labor and delivery and fun stuff like that. So I partnered with the senior center down the street, got to know the director. I did a pilot study with the community leaders. And I said, this is what we'd like to do. I'd like to bring my students to the senior center. I'd like them to get to know the participants at the senior center. And I'd like to eventually get permission to do a geriatric depression scale at the senior citizen center. This opened up a whole new world for those students. So that's what we did. So the students were required to go have lunch with the seniors at least twice during the semester, because as we know, older adults don't talk to people and open up unless they trust them. And they're not going to trust them if they show up and leave for a half an hour a week. So I said, this is your charge. So they did. The students did it. They thought it was like one of the fun things to do. So then after I got permission from the director, I I wrote up a lot of area community mental health centers and places where anybody could get services if indeed they felt like they were depressed. I had those to hand out. We took fun little trinkets to the people that everybody got. And then we invited them if they wanted to do the screening test with us, and the students administered them. And some older adults did not want to do that, which was fine. They still got a little trinket, which they loved. And we discovered 2 on the screening exam that needed further assistance. And the director knew these people so well that she said, we know they're already getting treatment. I said, terrific. But the students got to experience that. They got to be in the community. They weren't in a facility with people who were not only up and around, but also needed hospice work, and some of them didn't have it, which they felt at that time was depressing. They weren't mature enough to understand. So they thought this was really fun. So they really enjoyed that, which kind of irritated my cardiac care people because they usually just love that. But that was fun for me too. I really enjoyed it. I've worked with older couples in psychotherapy. Older couples that have married previously have issues. They bring it to the table. They may be in their 70s. They're still having issues because of things that have happened. You know, a lot of times, and I've been lucky. I've had people that could have access most of the time. People that are out there trying to take care of each other and that don't have access to work out communication problems among themselves, then they have more problems. They start going to clinics for physical issues that may be mental health issues. Okay, I also have done groups. Now, most people don't want to a group called an older adult group or a senior citizen group. So I ran a mature women's group, which was limited to people, women, 50 and older. I had a huge turnout. Again, I was lucky. These are people who had access to get to my clinic. However, some of them were in assisted living and they had buses, you know, from that facility that could bring them to where they were. They came. The diagnoses typically were depression. I did have some folks with bipolar disorder. I did have some people with eating disorders. But they bonded and it decreased social isolation. We had at least 2 hoarders in the group. And some of the women were going to take care of some of the other women and help them unhoard. That was up to them. I didn't pass out any information about each other's personal information, but they would, after the group, they would get together and say, how can I reach you? And then it became a real support system for each other inside the group and outside the group. Each group had goals. We got to know each person, but the group became kind of bonded. And then when people felt like they were ready to go, new people would come in. But it was a way to decrease social isolation, a way to help people understand how to live without some of the burdens they were carrying around, how to get the help they needed, and how to talk to their care providers so that they would get results. Okay, we already talked about the concern about Medicare not allowing primary care and mental health visits on the same day. Okay, so getting to recommendations for older adults. I really like some of the things Ellen said. I'm like, yes, yes. So the first thing that APRNs would like to see happen is eliminating the state mandated collaborative agreement that prohibits APRNs from practicing at the fullest extent of their education and training. What we've seen in the 28 states that have already eliminated that contract is that more APRNs are moving into rural areas. And if you talk to the Legislative Rural Caucus, they're thrilled about providers moving in to their areas. Family practice providers, mental health providers, any providers, they're happy to see that. We'd also encourage supporting schools of nursing as they try to hire faculty for graduate psych mental health education and ensure better undergraduate experiences. Everyone who's here knows that older adults don't just live in long-term care facilities, right? Hello, I'm an older adult now and I do not live in a long care facility. I may someday, but that's not on my agenda right now. And I'm lucky that I don't need to. I can access who I need to see. I know people who cannot access who they need to see. They have to rely on friends, family. I love that family thing you were talking about. And it's difficult because the family member doesn't know how to speak for their sick loved one necessarily, but they try. So schools of nursing definitely need some help with finances. APRNs are offered $60,000, maybe $80,000 to do full-time faculty work in a university setting, some much less. Out in clinical practice, many APRNs can make $100,000 plus. If you're supporting a family and you have a choice between $60,000 and $100,000, what would you all do if you're the sole breadwinner for your family? You're probably going to take the higher salary to support your family. Some people are lucky enough and they have 2 breadwinners and one of the breadwinners may get more money and then therefore a faculty member can emerge. But we need to help these people so that they actually can teach mental health, because we don't need people that don't understand mental health teaching mental health. And sometimes that's what will happen because the universities are desperate to get the faculty. And I'd love to see provisions and requirements for better education and training for primary care providers to assess for mental illness, especially in older adults. We probably all know that we go to the physician and they care about us. They want to make sure that we're safe, but they only do the PHQ-2. Like, are you still interested in things or have you felt hopeless? There's a lot more going on in people than those 2 questions. But you know what? That's all they have time to do because there's such a time crunch. I would love to see facilities allow longer times to work with older adults because in my experience, older adults don't get right to the point. It involves a story. So if you're available to listen to the story, you can tease out what's going on. If you're not available to do that because you have 13 patients waiting in the waiting room, they may not get to say what they need to say. Some do, some can, some don't. So leaving you with those thoughts, I'd like to thank you for inviting me to come and inviting CAPNY to participate. And I hope this has been informative. Thank you.
Thank you so much. Questions for Leslie?
So I'd love questions if you have. I
Jay,
have a bibliography out there too, a reference.
so thank you so much for your presentation. I couldn't agree more about the collaborative agreements, having ran several behavioral health units and knowing that that really is just an administrative burden as far as for physicians to be able to kind of check that box, and nurse practitioners is really what ran my units when I ran those. My question is, we've advocated for this so long at the State House. What are your perceived obstacles around that, and how can we get those obstacles? I know even DMHA was advocating for that on the competency side, using nurse practitioners, and there just is that natural resistance and obstacle that I don't know how to get around. Do you have thoughts on that?
Yes. There are parts of that puzzle us as well. I actually testified for the competency for the detainees last year. And the forensic psychiatrists believed that they were really the only ones that could do mental status exams that would be adequate for detainees. And so the backup continued. As you know, there were 7,000, 8,000 people in jails waiting for trials before they could be sent to either rehab or prisons. So the jails were full. So I think that advanced practice nursing education is not understood well. I think that's one possibility. I think that most of that legislators and many of the population are used to going to their physicians, which is great. However, there aren't enough physicians. There aren't enough psychiatrists. The psychiatrists in Indiana, I forget the number, but it's abysmally low. And I remember reading that one county had one psychiatrist for 60,000 people. There's no human way to take care of 60,000 people that have any kind of illness, let alone any kind of mental illness issues. And we know, as Ellen said, we know that depression and anxiety are tantamount for older adults, along with dementia and some of the other severe mental illness issues. But it is very difficult. And I think that we need to educate legislators better. I think that's one thing that can really be helpful. I think that using the data from some of the states that have approved nurses to be able to function without a mandated contract is helpful. But a lot of times, they don't have time to look at some of that. I think that, and especially in this short session, as you all know, we're all scrambling to try to give the information. Well, Steve, are you okay? Good. So I think those are a couple of things that we're looking at. So we're trying to get out more information and, share the quality studies that nurse practitioners have shown.
Yeah. Thank you for
Thank
that.
you for the question.
Yeah, absolutely. I think a statistic that is interesting as we're talking about the aging population that I want to say Bowen did a couple years ago is that our average age for our psychiatrists right now in the state of Indiana is the age of 70 as we're talking about aging. I just
Yeah.
think that's ironic.
And what we looked at in the APNA, the American Psychiatric Nurse Association, did a study, one of the very first, if not the first, certainly in the last 20 years, of a psych mental health workforce. And we showed that the average psych mental health nurse back in when the study was done in 2019, 2020, pre-COVID, and things have changed since then, was 46. So we also need, fresh blood coming up through all of those ranks, and the undergraduate, the bedside nurses, as well as the advanced practice nurses that are out in the community more than might be someone who's an undergraduate type student. Thank you. Any other questions?
Not a question, but just kind of thanks for being here today. And also just kind of highlighting, and Zoe, thanks for bringing up the collaborative agreement as well, because I think that that is also this aspect of removing that collaborative agreement with regards to the contractual agreement with regards to the behavioral health space. I think it's something that's also overlooked. I think a lot of times it's focused on that primary care side of it or just general health care. And I think that that's an potential opportunity in this space in particular to kind of increase that access and grow that workforce in regards to the assistance that folks need.
Thank you so much.
So
Anything else? No.
yeah, just a quick comment, and then I think we'll move to the next one. So I think our opportunity here, right, is because I think that one of my favorite quotes is that there's no solutions, only trade-offs, right? And I think when it comes to scope of practice issues, I think that what we have the opportunity to do here with this report and our recommendations is provide some clarity to the General Assembly on what those trade-offs are, because think about what they hear from trade groups all the time, right? They hear from ISMA or the nurses or the social workers, and those are sort of inherently slanted observations, right? Like, of course, the physicians are going to say one thing, and the nurses will say one thing, and the social workers will say one thing, and I think it turns into like almost like it's so confusing that it's hard for legislators who are bombarded with all kinds of, they deal with more than just healthcare, right? So they're bombarded with all kinds of issues. So I'm hoping we have an opportunity here to, we can certainly spell out a recommendation, but more than that, I think it's important to provide some clarity to like, okay, here are the trade-offs potentially inherent with whatever decision or recommendation you end up going with, as opposed to like sort of putting our thumb on the scale one way or another, because I think that when that happens, it sort of inherently brings out the other people and they get kind of defensive. And so anyway, that's just an observation. We can talk more about it when we talk about, lay down the road, we talk about recommendations and report writing, but I think that's something that's going to keep coming up is this scope of practice issue. And I think it's, and I'm a lawyer, so not a clinician, don't have a dog in the fight, but I think, we have our own scope of practice issues, but, I just think we really can, I think, provide some clarity. So that's really all I wanted to say.
Jay, if I can just jump in real quick again about that, because AARP has been working in this space for around the APRN and the contractual agreement for a long time, and trying to remove that for the increase to access. But I also think it does sometimes in the discussion, it gets lost about who this is really about. And it's about the patient, it's about the consumer, it's about making sure that they get the access they need. And it gets into this, us versus them kind of thing. And I think ultimately, any opportunity we have to provide a little bit of that clarity about what this is, who this is for and what this is about and what it can lead to and the outcomes that it could lead to, I think is going to be a great opportunity for us to take advantage of. And I think, like I said before, the fact that it's in this space is something I think is a different view than maybe has been presented prior.
Absolutely. Well, thank you so much, Leslie.
Thank you.
Appreciate it. So I'm going to go chair's prerogative, call a little 2-minute break here. And we'll reconvene in a few minutes. All right, if we could have a seat, you're going again. All right, thank you. Well, welcome back. Next up, we have Dr. Elizabeth Hathaway, who's a psychiatrist with Franciscan.
Hi there. I'm Elizabeth Hathaway, as mentioned. I am a psychiatrist. I'm very grateful to be here and have the opportunity to speak. I completed my residency training at the Indiana University School of Medicine and stayed there for my fellowship in geriatric psychiatry. After graduation, I began work with Franciscan out in Crawfordsville. So they have an inpatient geriatric psychiatry unit. When I say that it's an inpatient psychiatric unit, what I mean is that it's a locked unit where people are treated for acute and severe symptoms, usually those that endanger themselves or others in some way. So we most frequently treat dementia-related behavioral concerns, particularly aggression or agitation that can emerge as the disease progresses. We also sometimes see depression and suicidality, and we can treat other mental health concerns like schizophrenia and bipolar disorder. But most of my comments today are going to be focused on dementia because that's the bulk of what I see and what I can best speak to. Towards the end, I also have some more general comments that I'll get to. But so to start, I just wanted to provide some education around dementia. So when we say dementia, what that means is a cognitive decline from someone's prior level of performance, and it's to a degree that interferes with their independence in everyday activities. So the most common single cause of dementia is Alzheimer's, meaning that Alzheimer's is a type of dementia, but there are also other types of dementia. For example, there's vascular dementia or Lewy body dementia, and then many people also have a mixed dementia with more than one underlying cause. So in the early stages of dementia, it can be pretty mild. People might just have some difficulty with memory, trouble with planning or complex decision making. But as it progresses, people will eventually have severe communication difficulties and become completely dependent on others just for activities of daily living, like eating, getting dressed, going to the toilet. In terms of treatment, currently we have some medications that can give people a little boost and offset some of the decline for a while, but we can't reverse the progression of the dementia. There has been a flurry of activity recently with several new monoclonal antibody treatments that target a particular protein implicated in Alzheimer's. But that's all kind of evolving. It's been a little controversial, and right now access and coverage for those medications is very limited. And the treatment process is also very burdensome to the patient. They have to go through repeated MRIs, and there's a significant side effect risk as well. So dementia might not be the first thing that came to mind when you thought about coming here today to talk about behavioral health, but I want to emphasize that it's absolutely critical to talk about when we're thinking about the needs of older adults. Age is the strongest risk factor for dementia. It affects, well, so Alzheimer's in particular affects 1 in 9 over age 65. I think I was told that today is to discuss the needs of those 55 or older. From my perspective, anything before 65 is going to be early onset. But as people age, rates of dementia really increase. So again, focusing just on Alzheimer's, it affects 5% of people between the ages of 65 to 74, but rates increase with age. By the time you get to the 85 and older population, you're talking about 1/3 of people who are impacted with just Alzheimer's, not even other types of dementia. And the dementia means more than just cognitive changes. So it's accompanied by what are called neuropsychiatric symptoms or behavioral and psychological symptoms of dementia in up to 90% of those with dementia over the course of their illness. So that can be things like depression or anxiety that emerge as someone is dealing with the changes in their brain. But it can also be things like apathy, hallucinations, delusions, agitation, or aggression. And again, we can try to treat those with a wide range of medications like antidepressants. We use antipsychotics, which are much more closely regulated in the nursing home setting. We can also use medications that tend to typically treat seizures, but we can also use them to stabilize mood. But there's no perfect option. And especially with older adults, you have to be way more cautious with the dosing than most people realize. Older adults may have changes to their kidney or liver function that impacts how they metabolize medications, and they're at risk for side effects like sedation, increased confusion, or falls. Sometimes you try a medication and just right off the bat, it has a huge positive impact, and sometimes you have to go through multiple medication trials to really see much difference. So with these behavioral or neuropsychiatric symptoms, they're very common, they're problematic, and they cause significant distress both for the patient and for their caregivers. So I wanted to talk about caregivers today as well. Caregiver support is a major consideration when we're supporting the behavioral health needs of older adults. So if you think about someone who is trying to take care of a loved one with an advancing dementia, it's going to get to a point where they have someone who really needs round-the-clock care. They're going to need help getting dressed. They will need help going to the toilet every time if they are still continent. Even if the family is able to bring outside supports into the home, sometimes the person with dementia may be paranoid, hostile, or even aggressive to this unknown person who they find in their home. They also have significant sleep disruption, and there's always the risk that they could just wander out of the house at night and get themselves into a dangerous situation. So it's just a really difficult situation for a family member or other support person who's trying to provide care. In preparation for this, I had found a report called The State of Aging in Central Indiana that was done by the Central Indiana Senior Fund, part of the Central Indiana Community Foundation. And that noted that 1 in 3 older adults in Central Indiana provide care to someone 55 plus. So just another stat emphasizing the relevance of caregiving. But so when we think about these neuropsychiatric symptoms, those behavioral disturbances are associated with higher rates of caregiver depression, and the level of caregiver distress is more closely associated with those behavioral disturbances than with other aspects of the dementia. You can imagine, like, as much as families try so hard to keep their loved one at home as long as they can, it can get to a point where this is just totally overwhelming. So we also see families who have grappled with the decision to place their loved one in an assisted living or usually a memory care unit or nursing home. And I wanted to comment also on the cost, because that's a major stressor for families. Usually when our social worker is talking to families about placement, if they're going to be doing private pay, she quotes $250 to $300 per day. The cost of a memory care unit the range is $3,000 to $10,000 per month, with the average being around $6,000 or $7,000 per month. So that's a huge strain on families. As the population ages, the societal impact of dementia will grow. So I think it was mentioned earlier, as of 2020, there were 6.1 million in the United States affected by Alzheimer's. Again, one particular type of dementia that's the most common type. And that was associated with a $321 billion national cost of caring for those with dementia. But also not included was $271 billion in unpaid care from family and friends. So that's already very significant, but by 2050, the number of people dealing with Alzheimer's is expected to double, more than double, from 6.1 million to 12.7 million. So it's a real public health crisis. Given the reason that we're here, I also wanted to mention that dementia is more common in those with serious mental illness. So somewhere from 2 to 4 times is what I saw most often, 2 to 4 times more common. And in that population, it also tends to have an earlier onset. As I mentioned at this point, we don't have a way to reverse the progression of dementia, but obtaining a diagnosis and being able to treat the associated symptoms can really help to maximize the quality of life for both the patient and their caregivers, and it can help families to be prepared for what comes next. So things like goals of care discussions or advanced care planning is really important to have before the moment that a family is in crisis. At some point, I hear from family members that they just see that their loved one has a very poor quality of life. And I've heard people say if they could see themselves, like, they would never have wanted to live this way. So it does get to a point where it may be more appropriate to prioritize someone's quality of life versus just solely focusing on what's the most life-prolonging treatment. But it's important to be able to navigate those decisions with someone that you trust. I also wanted to say kind of the decision-making around various medical interventions becomes more complicated. Even something as simple as like placing an IV for treatment, we usually try, if we can get away with it, if someone needs antibiotics, we try not to do that on the unit, because what if they rip out their IV? People are more confused and not reasoning the same way that they usually would. But so as has been mentioned, despite all these challenges and the potential benefits of care, it is difficult for people to access. For geriatric psychiatry in particular, I would say it's very hard to access care. So when people are leaving the unit where I work, usually they're going to go to a memory care or nursing home. Most facilities have a company that they contract with, and someone comes on site to provide psychiatric care. So often they're seeing a nurse practitioner, and it seems like more places are moving towards that, but there are still some solo physicians or physician groups who round at the facilities and provide psychiatric care. For those returning to the community, it's usually harder. So when they're going to a facility, it's convenient from my perspective. There's a plan, there's care that I can link them up with, but it does limit their choice. If they're going to the community, usually we can get them scheduled with a general psychiatrist or a psychiatric nurse practitioner. But even with those where I feel like things are complex enough that they really need a geriatric psychiatrist, there are not many. At this point, I don't feel confident that I would be able to get an intake for them. And then with a dementia, neurology is also often involved in the diagnostic process, and those wait times are long as well. So usually in residency and fellowship, I tended to see people waiting 6 or more months to get an intake with neurology or psychiatry, and my impression is that that has not improved. Primary care was mentioned earlier, and I think that's an important thing to consider. Dementia tends to be underdiagnosed in the primary care setting, but I think education on resources and how to support families could go a long way. I also wanted to make a few more general comments about just kind of thinking about the societal level. What I wanted to highlight was the idea of social isolation and loneliness. So to clarify the distinction there, social isolation is kind of a more objective, the fact that someone has few social contacts. Whereas loneliness is more subjective, that someone is unhappy with their social relationships or perceives that they do not have enough social contact. But so these issues impact not just mental health, but physical health as well. So social isolation is linked with cardiovascular disease. They cited a 29% increase in heart disease risk. It's also linked with dementia, stroke, depression, anxiety, and also premature death. So I found one review that showed the mortality impact of social isolation was comparable to smoking 15 cigarettes per day. The highest rates of social isolation occur among older adults, and I wanted to highlight a couple factors that contribute to that. One is institutionalization. So many people live in nursing homes or some type of facility that is kind of cloistered from broader society. I know there are efforts for activities and things like that, but it can be isolating. And I have seen people who, they get to their assisted living and they love it. They love being around people, but I don't see a lot of people who are really psyched up to make that change in their life. Rates of depression in long-term care facilities are around 30% of older adults. But with better caregiver support, we may be able to delay or prevent nursing home placement. I also wanted to highlight transportation difficulties. So telling someone that they can no longer drive is always a contentious conversation. That's hard when someone lives in the city, and then being out in Crawfordsville, I feel like it's even harder in rural environments. There just are not a lot of alternate transportation options. And in our society, the idea of driving is so closely linked to independence. It's a huge loss for people when they're no longer able to exercise this privilege. Older adults are often also dealing with the loss of multiple family members and friends, and they may have changes in their health status. So even just a minor infection, people may not bounce back in the same way that they would have in the past, and that can be very discouraging for people to experience. I also found in that State of Aging in Central Indiana report, they mentioned that one of the biggest contributors to social isolation is disability in Indiana, and rates of disability increase, they said, from 18% in that 55 to 64 age group, all the way up to 66% in those who are 85 and older. So with all these factors, I really see people to grapple with a loss of control in their life. And I wanted to mention again that the highest suicide rates are seen in males who are over 75. I also found in that report that 1 in 3 older adults in central Indiana report feelings of loneliness or social isolation. So it's an issue. And just wanted to encourage that public policy to help support social infrastructure can help remove those barriers to connectedness and help people find a continued sense of purpose. So thank you again for the opportunity to speak, and I'm happy to be in touch in the future with questions and follow-up needs.
Thank you. Questions for Dr. Hathaway?
Just one from me is you have this experience of where you've worked, in Indianapolis, and now you're in a more rural setting. Can you just speak a little bit more to the kind of the challenge on that rural setting of people that are coming in, where they are in that diagnosis? Would they have been, if there was more access where they were, would something have been caught earlier, or would they have been able to get kind of on that path with regards to their family on treatment, if there like that access was there, especially in like our rural areas? I feel like that's a challenge you may be dealing with more so than folks in Marion County or wherever.
Yeah, I mean, I by virtue of where I practice, I tend to see people who are later in the disease process. I do feel like we have more patients out there, and if I'm coming up with kind of an image in my mind, it's that I have seen way more like farmers who have just plugged away on the farm their whole life and then are coming in very late in the diagnostic process. And it's like, oh, families can normalize a lot and say, oh, this is just part of aging. So I do see people where it has advanced fairly far before there's a recognition that this is not normal aging. I will say though, even in Marion County, right now we have limited treatment options. So even there, I encountered people, you have to tailor what workup you do to what their values are. So sometimes people were like, I'm concerned about this, but I don't want to know. What's going to happen is what's going to happen. And at that point, you just try to support them with any symptoms they might have along the way. It's going to, I don't know how things are going to evolve as we have these new treatments that can help with the amyloid involved in Alzheimer's. Most of the people I see, those were approved or partially approved for people with early, like mild dementia. So the people that I see would not be eligible for those treatments. If those become more widespread, that's going to be a huge strain on the system. It's a ton of imaging, a ton of very subspecialized evaluations that need to occur. And it's extremely costly. In 2022, the Medicare Part B premiums had their biggest dollar value jump ever, just in anticipation of the potential costs from those treatments. So anyway, to go back to your point, I would say I do see people who have had a delayed diagnosis. At this point, it doesn't necessarily make a huge difference in my treatment decisions for them, but I think it could improve their quality of life and their families if they had a better understanding of what was going on and how they could intervene. And I think my statements on that will probably continue to evolve as our treatment options evolve as well.
Other questions? Zoe?
So first, thank you. Thank you for your work as a geriatric psychiatrist in a rural community. You are definitely a treasure. And so that's my question along the line of workforce. Like, what made you get into that? What made you connect with that? It's a significant gap, the specialty in our state. And so any suggestions along that line?
Well, I think I had been pretty close with my grandparents. So when I started medical school, I really enjoyed working with older adults. And then I also had anticipated I might go into neurology or psychiatry just because I thought that the brain was so interesting. I would say as I considered career paths, I think one hurdle is, as we mentioned, sometimes older adults really like to tell a story to get where they're going. And there's huge time pressure practicing medicine these days. It is really hard. With inpatient, I have a little more control over the flow of my day, but in outpatient, it is really hard to be patient with someone when they're kind of making a big loop to get to their point when you have in primary care, what, like a 15-minute visit. I was interested in family medicine as well, but that kind of influenced me towards psychiatry, both because I really cared about the mental health concerns, but also I knew that there was more protection to have the time to provide the care, and really understand the patient's situation. So I know it's a huge systems level issue, but I would say that having the support and the protection in the field to be able to take the time that is needed with patients kind of gave me the confidence that this was the right path for me.
Okay, I had one question on the sort of over medication polypharmacy, because I hear this a lot kind of anecdotally, especially, I mean, not just older adults, but just kind of in general with really complex, severe mental illness issues. But in your experience, I guess two-part question, how common is that? And are there things that we could do from a policy standpoint to combat it?
Yeah. So the biggest place that this comes up is that nursing homes are tracked really closely on how many people they have on antipsychotics. And I think those policies were well intentioned. I think there is certainly, it's easy to overuse these medications, and it's certainly easier for places that are staffed very thinly if most of their patients are sedated and not acting out. So I think that things were overused in the past, and I think that the policies were implemented with good intentions. A number of my mentors who have seen the evolution of things speak pretty passionately that at this point they worry it's causing more distress, that people are having symptoms that facilities are reluctant to address because of how it would impact their metrics. It's a little more of a battle to use medications that may be appropriate. But that said, I'm coming from the perspective, I did extra training because I want to provide really nuanced, careful care. So I understand that guardrails may need to be in place.
Absolutely. I mean, it's a very complex conversation that, I
Yeah.
can barely understand. So I appreciate your shedding some light on it. Great. Well, thank you so much. I really appreciate your time and expertise. And I'm sure we'll follow up if we have any questions or there's other questions for you. Thank you. All right. Next up, we have Tony Murray, who's the president of the Professional Firefighters Union of Indiana. Thank you, Tony.
Well, good morning, everyone. Thank you for having me in today. Thank you, Amber, for the invitation. And it's a great opportunity to speak with you all today about mobile integrated health care programs. I am Tony Murray. As the chairman said, I'm the president of the Professional Firefighters Union of Indiana. But outside of that, I've been working in EMS for 30 years, nearly, on Valentine's Day. First certified as an EMT back in 1994, and have worked as a paramedic now since 1997. I trained in Indianapolis at the old Wishart Hospital through the IU School of Medicine program. That was one of the first degree programs within the country. And I've worked largely my career in the fire-based EMS as a firefighter and a paramedic, but also I've had experiences through county programs, county services, and also in the private service. My experience particularly related to mobile integrated health, or MIH. For 2 years in my fire department in Noblesville, I worked in the space where we began a mobile integrated health program to address some specific issues within our community response. So often, and I'm going to talk a little bit more in detail about this, but so often for many people, the acute nature of an ambulance call or dialing 911 gets you a bunch of different resources. And oftentimes, we get to know people over time, but I'll get more into that in a moment. But for 2 years, I really enjoyed coming off of the fire truck and sort of working independently, even off of an ambulance, and working more within the community. This was during COVID, actually, as well. So it brought some unique perspectives. to the table as well that I'm happy to talk about. So that's been my experience. Now, in my current day-to-day activity, I advocate for our issues at the Indiana State House. As an advocate and registered lobbyist, we do our own lobbying. So some familiar faces and all for my friends in the hallway. So this gives actually a great opportunity, I think, to help discuss on specific pieces of legislation that are being entertained by the General Assembly to provide a perspective, I think, during committee hearings. And we do advocate for expansion of MIH programs across the state, which I'll get into a little bit as well. But our EMS engagement, emergency medical services engagement, really, we have a unique perspective about understanding needs beyond the 911 call. And that's really what mobile integrated health programs are. Initially, we started looking at the concept of what do we, do MIH? Is it community paramedicine? It was anything but the emergency side of what we do. And originally, when we thought about this concept, the original thought was, how do we reduce our 911 calls? So it sort of seems maybe a little bit counterintuitive, right? But at the same time, we sort of did that in the fire service really well for decades in fire prevention. So fire calls are down. That's one of the reasons why fire service is now part of the EMS, offering EMS and providing EMS. So in doing this, it became really more than just reducing what we call our loyal customers. So the person that calls and we see on a very regular basis for a variety of reasons, right? So we're beginning to understand more through mobile integrated health about understanding the needs beyond the 911 call. So we're in the space of now, when we have a MIH program set up, it's really largely based on what the community risk assessment tells us that the issues are. We may think that there are certain issues within our community, but really having to rely on it, and the results of a community risk assessment tells us what actually are those issues when it comes to the things that we deal with in MIH, community paramedicine. Largely that could be chronic illness. So ensuring that people, making follow-up visits and enrolling people that we sort of deem through our emergency response, and our crews have the ability in mobile integrated health programs to send a referral. And then we may reach out to that person to say, we noticed that you had, a call for an ambulance, and would you like to participate in having a little more information? And it's not something that is required. Certainly, it gives us an opportunity then to reconnect outside of the emergency. And sometimes that's just dealing with chronic illness issues, whether that be trying to keep patients med compliant or helping them with their modalities that they use for, let's say, COPD. So we don't have a reoccurrence, or at least minimize the reoccurrence of exacerbation of that sort of thing, or compliance with some diabetic education and trying to work through that. So we're not going when they're unconscious and have a blood sugar of 30, because we all know sort of that process is sort of not great. Through these visits and through these calls, we begin to understand the voids that people have in basic care needs. We talked about, and we heard some great things about family advocacy and having people engaged. Well, all too often we see the reality of when folks don't have an engaged family member or do not have those opportunities, whether they're maybe abandoned from their family, which is many times the case, or they have grown children that are outside of the area. Oftentimes we're talking with those grown kids somewhere else in the country on the phone while they're standing in their mother or father's living room. So understanding the needs and sort of being that replacement advocate, I think has enabled us to see the ability to care for people better and really sort of achieve one of those, I think, pillars of reduced calls for 911 for whatever the emergency. Also in these programs, we're able to connect resources other than the emergency department. So if we have the opportunity to revisit, have a conversation, understand the patient's needs and struggles a little bit better. In an emergency call, we're dealing with the acute issue. And there is pressure because there are other calls, right? So we need to, much like in the primary care or specialty care, we have to become available for the next call. Otherwise, calls penned, and people who need us, we're tied up. So we do try to expedite our service. But our entry for nearly all patients, unless they sign off and say, I don't want to be transported, the only opportunity we have for transport, we provide the out-of-hospital care, but we have to go through the emergency department. And I'll get into a little bit more about some of the complexities of that in a moment with regard to specialty care, and particularly around the mental health and behavioral health side of things. In mobile integrated health programs, we also are able to develop relationships with patients. We get to know them, provides a better understanding of what their real challenges are. But more than anything, it allows for us to create relationships with other organizations or other providers. Whether that is some examples, maybe we're being called for constant or more than a routine slip and fall. Maybe without injury. We can take a look at the living environment. Maybe we have throw rugs. Maybe we have things that can be changed, or maybe we need to have more grab rails to help. Maybe we need to eliminate the steps into the entryway. You talk about isolation and that sort of thing. What can we do and what can we recommend to help make a person's quality of life better, but also keep them out of the ER and keep them out of the back of an ambulance? Understanding what's available in the community or reaching out, we're able to then make recommendations for what we know are accessible in communities. Oftentimes, whether there's an inability or people just don't think, or they're embarrassed to call for agency assistance or community assistance, I think we can make those recommendations, but we can also make those connections as well. So we've done things such as eliminate a couple of steps into the entryway of the house and replace it with a ramp. Have somebody come in and some people that volunteer to come in and do installation of grab rails and things like this. And those are just a couple of examples. But it is through these relationships and understanding what's available within a community, we can connect those patients with some of the resources and improve their quality of life. Through MIH and follow-ups outside of the 911 call, additional services that we can identify, we're in people's homes. So we're able to observe, things in their surroundings and their environment, whether they have food insecurity, whether they have the inability to go out and get food. So one of the things we could do is connect them with services that provide meal service, such as Meals on Wheels, to help meet hunger and food challenges. Identifying that maybe, and perhaps it's not obvious, but we get to know somebody that maybe served in the military. So we're able to then help that person connect with VA services that they would not reach out for themselves. We make the assumption that people, well, you're in the military, so you know what the benefits are. Often people do not. But if we have a specialized team and a specialized group through MIH, we're able to make those connections as well, which can really make a difference in identifying, but also treating health challenges. Mental health needs as well. So I mentioned that we're in the home. We're talking to people. We may not have been initially invited into that home because of a mental health crisis or a mental health need. It may be for chest pain. It may be for a fall. It may be for simply an invented reason to call 911 because somebody's scared or lonely. They know that somebody will come. But when we look at this and we are able to then identify maybe that somebody is having some challenges, a person is having challenges with mental health, that they may not understand that that's what it is. So through that, and obviously we're not treating those things, but we need to provide, and we do provide through this more follow-up nature and connecting resources, providing them with the solutions that they need for their mental health needs, which tend to improve their overall health, as you know. We do things such as medication reconciliation or compliance, and also help to connect people when we identify and address loneliness. One of the things in an example during the pandemic, part of my job and our folks in our mobile integrated health program was to participate in the Homebound Hoosier program, which, if you're not familiar with that, it was a way to directly provide COVID vaccination to people who could not leave their house due to the inability to do so, or in many cases, who created one, they were already isolated, but they created additional isolation because they did not want to leave their home for fear of contracting virus. So through that, we entered people's home, and I gave hundreds of these inoculations myself. And there was a period where you had to wait 15 minutes to see if there were adverse reaction. Those were some of the most valuable 15 minutes for some of those people ever. And of course, we had to do 2 rounds, so they were happy to see us come back. That really sort of created an awareness that there is a bigger problem when those people were so happy to see us come to give them their shot. In the mental health space and how MIH can help address those needs, I think, again, going back to connecting services and treatment that aren't necessarily delivered efficiently through the emergency department. So as I mentioned, somebody may be having a mental health crisis. The only option that we have from the 911 call is to take them to the emergency department. We are expanding that a little bit because those are the rules. That's the only place we can go in an ambulance. Now, through mobile integrated health and specialized training of some of our people understand that, and working with law enforcement, we are able to, because law enforcement aren't held to the same rules that we are when it comes to emergency medical transport. So there are relationships where there's side door access to mental health standalone facilities. We can put a patient into a police car if they don't have any extenuating, through our assessment, medical needs that need to be dealt with and cleared in the emergency department. And they can go right into the side door of that mental health standalone facility to begin getting the care that they need. Otherwise, if they go in the back of the ambulance, they're obviously going to be treated for anything that is in conjunction with this mental health crisis. But if it's clearly and singularly a mental health crisis, go to a community hospital, they may not have behavioral health services available. So they may be waiting as they call for somebody to do an evaluation. So one, they're occupying a bed. They're not necessarily getting the care that they need and expect, and they're staying there for longer. Now, if they have to be assessed there and then maybe transferred by ambulance to an inpatient facility, and you see sort of that goes on and on. So I think if there's an expansion of our ability as paramedics and EMTs, outside of our only alternative, putting somebody into a police car, I think that would benefit our ability to take care and provide for proper care by bypassing the emergency department. And as we know, that is one of the, or if not the most expensive entry into our healthcare system. Access to mental health services through mobile integrated health needs to include more of these direct access points to the appropriate care and treatment. And that goes to expand also to other areas as well that I won't get into, but like such as immediate care clinics and things like this. Give you an example of how we've tried to change what we're doing in this space. Is a few sessions ago, we worked very closely with Representative Shively to address and craft legislation which was signed into law that allowed for the existing mobile integrated health programs to get feedback and a discharge information from mental health facilities, behavioral health facilities. So when patients are treated and come back into the community, we can follow up with them and help them stay in compliance with their risk plan, and help and visit to make sure that they're doing all of the things that they were prescribed to do, which in effect eliminates, hopefully, the idea was to eliminate the crisis from occurring again, because when there is a mental health call or call for mental health crisis, that 911 call generates not only the appropriate ambulance response, but it also generates a law enforcement response to ensure that EMS providers, firefighters have a safe environment, in a place where there could be violence or nature to violence and that sort of thing, which people that are have mental illness or these diagnoses are working through this, we want to eliminate, if we can, the crisis nature and putting more and more people with uniforms wherever this person is. And what I'm trying to say is we want to de-escalate those things, because you already are dealing with some situations through, behavioral health, and you add in a bunch of people you don't know wearing uniforms, and you don't know what the outcome is. We've seen it time and time again. Those situations create more anxiety, more stress, and often that may result in a patient then being incarcerated because of, or at least arrested, detained, what have you, because of demonstrating threats and that sort of thing that put other people at risk. If we can try to de-escalate those and eliminate the crisis, it helps us. So part of that effort is to eliminate those 911 calls and have more of a partnership with the mental health provider and facility. I think that that's slow going. The result of that is slow going. And we'd like to see that, I think, more interaction and partnership with mobile integrated health programs and behavioral health providers and specialists to feel comfortable in sharing that information with us. Ultimately, those were our patients originally, and they're still going to be our patients that we respond to in the community. So funding, as I begin to conclude here, or wrap up, most mobile integrated health programs, and we don't have very many, there's less than 2 dozen in the state. These are funded through and supplemented by fire department budgets or EMS budgets that currently exist without any new funding sources. So there's decisions that have to be made. I think that we could have more of these if there was a funding mechanism, and we're beginning to build those through legislative action, creating grant programs, and to stand up more mobile integrated health programs, not only for mental health, but the variety of things that can be addressed here successfully. In addition to bringing some more resources that are expert resources, whether that be a social worker or behavioral health specialist alongside of a law enforcement EMS to build that team. So a need for reimbursement for services. This is something that we've worked on as well. Most reimbursement prior to us changing some things or working with some folks to change the laws a little bit, the ambulance transport was only reimbursed if you took a patient in the back of the ambulance somewhere. As you can see in mobile integrated health programs, we're actually working to do the opposite. We don't want to take anybody anywhere. We want to follow up with them. So getting reimbursed for those services is going to be important. And just briefly to talk about successes, it's difficult to measure right now because these programs are so new and are constantly evolving. They're very fluid in nature about what they're addressing. But I think that over time, we'll be able to capture more data to be able to tell that story a little bit more about successes. Anybody that's working in this space will have anecdotal stories of the person that they were able to help. And that is their success story. And I think that AARP has done a great job of trying to connect a lot of these great stories. A couple of weeks ago, I was out to a program that Amber put together to begin to tell the story a little bit through some video capture of some real success stories. Traditionally, and in this case too, as the fire service evolves, we're evolving with the needs of our community. So I think that we're appropriately positioned by the very nature of the work that we do within our communities to have lasting outcome and evolve with these needs as well. Happy to answer any questions, and I hope that you found that to be informative.
All right, thank you, Tony. Questions for Tony?
Hi, thank you, Tony, for being here. I want to applaud the professional firefighters for putting so much efforts in this program, taking the lead. That's very admirable. As a county official and a longtime first responder myself, in rural Indiana, we don't have the luxury of many professional fire departments, as most of everyone knowing that. So a lot of those have become hospital-based, and even some health departments are dabbling in minor integrated health programs. So I just want to shed some light here, repeating you have about a dozen in the whole state, correct?
I would say less than 2 dozen.
Less than 2 dozen. I misheard you. So there have been some hospital-based programs in rural Indiana that just in the last few weeks that have been CDC funded. And those programs statewide have been defunded. It is becoming even harder in Indiana to grow this program in homes. So I hope we can find some solutions to continue to grow it in rural Indiana, because without that face-to-face and in the home, it is really hard because of all the restrictions of transportation and not able to leave. So thank you for being here.
Questions for Tony?
So okay. Sorry, I've been talking a lot, but I guess today's my group's jam. So that's what we're here for. That's what we want to talk about. And you hit a little bit on that kind of that rural community aspect. Tony, can you talk about, and I know that you're familiar with, and I appreciate you plugging the video. And I'll make sure that members of the commission are able to see that. It's on AARP's website, aarp.org/in, and you can find it there. But I'll make sure everybody sees it. Where we do highlight, Monticello is one of the communities that's got a growing one. I know Crawfordsville has got a very robust and kind of a national model. Can you, I guess, talk a little bit more about how that has expanded access in rural areas, and with you all being on that front line, that you can help to be kind of that, I guess, early detection, if you will, for folks that are struggling with some of these behavioral health type issues. Because I know that, and just because we recorded this video and things of that nature, I know that from like a readmittance rate, it's stunning numbers, I would say. But if you can just speak to a little bit of some of those successes that are happening in those rural spaces and how those have been growing and thus far
Sure.
with the limited resources that they do have.
And some of this too, Jason, really was inspired by the regulations in the Affordable Care Act and with readmittance and the sort of penalties that insurance companies and hospital systems, were going through with that. So they needed some outreach and some people in a space to help them try to keep people out of the hospital. So that's one of the areas, and that was probably that was several years ago. In the rural setting now, it was interesting what the doctor said about farmers, because I've also worked in that rural setting environment in EMS. Probably some of the most resilient people that I've ever met in my life, but and probably stubborn too when it comes to healthcare matters. They would call us way later on in the initial onset of chest pain. But there's always a struggle in the rural community with regard to the services that we offer. It takes longer to get there. Generally, there's more space to cover. And with that, though, there are certain challenges, I think, to your point, that have been addressed in Crawfordsville, for instance. And one of the things, and they have a very unique, at least at the time they developed, it was a very unique niche service that they were addressing, or issue that they were addressing, and that was prenatal care. And you wouldn't think that, well, the EMS or the fire department is involved in prenatal care, but it was a desperate issue in that particular community for prenatal care and education And it was the mobile integrated health program that was helping to do that. And I don't know exactly why. I would say that there was a challenge with regard to maybe OB maternity care, that sort of thing, and access there. But also, I think that trying to connect and recognizing what the issue is in your community, and that is different in every place, rural, urban, suburban, it doesn't matter. But does that answer your question a little bit? I think that I would say that through identifying what the issue is in the rural setting,
Mhm.
we're able to develop programming, although it's slow to go right now.
Yeah, and I think that I guess highlights what you're saying is the flexibility of these types of programs because each community is different. So that means each mobile integrated health program is going to be different. And I know that, up in Noblesville is focusing, they want to focus theirs on in the mental health space. Some of the other ones are around just general healthcare and things of that nature. But I think that this is just, as we've been hearing from folks today about access and, getting more services, I feel like mobile integrated health is a flexible option that has potential that we should, as we look for policy ideas and ways to grow things, that this is just kind of one of those programs that can help in a variety of settings.
And if I may, just to point out something and put a fine point on it, there's already 911 calls going on. There's, we're responding to things. Providing additional services requires additional people to do that. So these are considerations as we build out these programs and not taking off there's plenty of problems. We all know that. But we don't want to take off at too big of a chunk. So we're in a situation where we're over promising and under delivering.
So Tony, I know I think you're familiar with our efforts to build this sort of statewide behavioral health crisis system, of which sort of mobile crisis teams are a key component. I don't see these things as being in conflict. I know that's not a consensus opinion necessarily. But can you just, from your perspective, what's the level of familiarity, I guess, with mobile crisis, and how do these two things kind of work in tandem with each other?
It's not very familiar, at this point. And I think that probably the overarching term that I could use here would be coordination. So there is going to be a need for coordination and communication and sort of the synergy of efforts. I think that all of these things in terms of trying to face some of these challenges head on needs to be coordinated. The go-to is 911. You have a problem. What do? You pick up the phone and call 911, or you observe somebody else having a problem. You call 911. That's the go-to. I think that through more communication and more coordination, we will be able to change that culture, I think, a little bit with regard to that. And there's some other programming that on the back end that I think that we're having conversations and exploring. And that's sort of when the call comes into the call center, whether it's, whatever three numbers you're dialing, that there is a coordination on that and to send the appropriate response. And that's going to be a need for future build out and some investment.
Yeah, absolutely. And I should say, just for the record, like we're trying to get folks in the direction of calling 988 when there's in fact a behavioral health crisis, although we understand it's going to be a long, 911 took 50 years to build up. So we're hoping
We've
to
done a good job of communicating.
Yeah, I think we're doing very well on interoperability, I think. So great. Well, Zoe, do you have a question real quick, and then we can move next one.
So thank you so much. And thank you so much for your service. So as I'm sitting here thinking of all the mobile options in our communities, and I'm thinking of behavioral health, to me, if we don't do that coordination, we create silos. And if we don't connect folks to the appropriate place at that initial point, we can lose them for that point of treatment. And so there's mobile healthcare teams like you're advocating for. There's the mobile integrated peer response teams that a lot of our communities have lifted up that have been, like where I'm from in Tippecanoe County, super impactful in decreasing overdoses. And then there's also, like Jay said, the mobile crisis team. So to me, it's the confusion for the more portals in, the more confused people are to what point that is. And so I see a lane and a specialty in each of those for folks. And if we could maybe try to stay within that focus and help support in collaboration with folks, I think that would give us a bigger bang for that clinical impact, if that makes sense. So I just wanted your thoughts on that and kind of along Jay's question, how that all fits together within this infrastructure.
And I appreciate that, those thoughts. And I think my mind goes to generally recognizing that there's an issue comes out of some sort of acute situation. And that acute thing is the emergency, right?
Mhm. Yeah,
Um,
that's true.
I think that through coordinating through the acute issue, I think will help. And by coordinating, I mean, there's an acute response to that. We're going to provide out of hospital care. We may pull somebody into a mobile integrated health program. But again, it goes to those resources. If that's the center point, or the center of the wheel, our ability to expand out and find those other groups, maybe that takes, that's a great use of resource to where we don't necessarily have to put that on our list to follow up, that we've resourced that out to other appropriate groups. And some of this, I go back to sort of checking in on homeless people behind a strip mall who we knew, that's where they were, that's where they stayed. Checking in on them and knowing that they were there, one, is very important. But two, checking into them on very, very hot days and very, very cold days. And just, from time to time, maybe they weren't ready to go into, and maybe we're working with them. I'm just as an example on mental health issues, maybe, or addiction issues. Maybe they weren't ready to go in for help that day, 2 weeks ago. But by checking in, we were able to get them the assistance that they needed. My point in that is, those are more and more people on the list to have to check in. So by expanding and sort of creating a community that we're able to pull those resources in, gets people the help that they need in a more efficient way. I hope, if that makes sense.
Great, thank you. And just to kind of sum up, I think we'll have these conversations, I think, ongoing with the commission. I think this is a good example of what I think is an interesting tension we'll have to navigate, which is like ultimately, like, we want to center the individual, or the person who's receiving the services that needs our care is the most important person in this conversation, like by far. Like that's but we also recognize that there's sort of a critical mass that the system needs, as well as finite resources the system needs. And so how do we make sure that our systems, whether there's CCBHC, CMHC system, or mobile integrated health, kind of all play together nicely? Because ultimately, you're going to be called out for things that have nothing to do with mental health, right? And so, but we want to make sure that you are equipped to handle when those things arise, and that's really important to us. So I think it's going to be interesting for the commission to grapple with, is like, we got to make sure that, we prioritize the individual while also understanding that there's a system that needs to be built underneath all of it. So thank you so much, Tony, for your comments, and we'll just jump right into the next presentation. Kristen, if you wanted to come up. Thank you.
Good morning. Well, almost, no, we're still morning. Good morning, everybody. I'm Kristen Lais. I'm CEO of the Indiana Association of Area Agencies on Aging. And just want to thank you. We're very pleased and interested to be here to provide the area agency on aging perspective on behavioral and mental health issues that we're running into on a daily basis as we conduct our work in Indiana's long-term services and support system. And so with today, want to walk you through, some of you may be hearing the term AAA for the first time. So we want you to know what our role is and then highlight where area agencies on aging are showing up in older adult behavioral health. I want to share with you, based on those experiences, some of the critical issues we're finding and that we would ask you to prioritize in any final report that comes out. And just some of our ideas about sustainability. We know those solutions will all probably require resources, and we just want to toss out some of our ideas towards those resources. So when you hear the term AAA, especially this time of year where we're in pothole season, this may be your vision of what AAA is, right? And I certainly have my own AAA membership and really make use of them when I get a flat tire or a dead battery. And God bless them. We want them to continue, but we are the other AAA. We are area agencies on aging, which were established by the Older Americans Act in the 1970s to respond to the needs of Americans age 60 and over in every local community. And we assure in a local community a range of options that allow older adults and people with disabilities of any age to choose the home and community-based services and living arrangements that suit them best. So our mission is to make it possible for Hoosiers to live and age in place in their homes and communities. And here's a big laundry list of just some of the home and community-based services that you can access through an area agency on aging. One of the things that we talked a lot about already are caregiver support and respite, and so we'll have some more comments on those. Jay, at the beginning of the meeting, mentioned some of the concerns about the Medicaid budget, which have been driven by, in some part, in a large part, by attendant care services for particular populations. So there's just like a whole list of things that people can access, and it's our job to assure these range of options exist in a community. So there's a big community planning function. AAAs at their best are helping communities stand up responses so that these services can be provided. We also are helping individuals navigate these kinds of services and providing ongoing care management. We may be direct providers of these services. So we work at a lot of different levels with communities and individuals to make this system happen. Our network is comprised, this is a little confusing because there's some history here. We have what are called 16 planning and service areas in our state. So every county in Indiana is assigned to one of these planning and service areas. So wherever you live in Indiana, you have access to a AAA, but we have 15 organizations that manage these planning and service areas. So we have one AAA that's covering areas 6 and 9 on the east side of the state. And we are the expert front door to long-term services and supports in Indiana. We've been innovators regarding social determinants of health since the 1970s. And so when the Affordable Care Act came out and everybody started having the word social determinant of health coming out of their mouth and the newer term, health-related social needs, we raised in our hand and said, we've been doing it for 30 years, 40 years already. So get us involved in this game. So because of that, we're involved in complex care management for all ages. As individual nonprofit organizations, with which all our AAAs are, we are leveraging multiple millions of dollars of private fundraising investment into the long-term services and support system. We advocate. So we advocate, fund, and coordinate home and community-based services, and we serve that front door. And we heard a mention of the No Wrong Door system in Indiana. Part of that No Wrong Door system, or a former term, would be Aging and Disability Resource Center, and we hold that designation for the state of Indiana. So just to give you a little bit of a national perspective, AAAs exist nationally. They exist within kind of this network of organizations led by the U.S. Department of Health and Human Services Administration for Community Living. And there's also significant connection with CMS, the Centers for Medicaid and Medicare Services, as a result of the billions of dollars of Medicaid funding that nationally support long-term services and supports. And the funding that comes through, typically from the Older Americans Act, vests with state units on aging. So when you look at states and territories, there's 56 of those. Somewhere plus or minus 650 area agencies on aging nationally. There are tribal organizations that kind of act as both a AAA and a unit on aging, and of course, tens of thousands of in-home service providers. So states manage and fund their HCBS networks differently, and AAAs work with their state units to design those. Some states have one AAA per county, for example. Some have one for the entire state. But we're kind of involved with state units on aging, our local service providers, consumers, families, kind of that nexus, and making sure these things happen for our communities. AAAs vary across the state as nonprofits serving their communities, but they all have 5 specialties. I mentioned the Aging and Disability Resource Center, in which we're providing specialized information and assistance as a kind of an adjunct to Indiana 211. So we have resources in our database that are very specialized to older adults and people with disabilities that maybe Indiana 211 doesn't house. So we bring in the 211 data and act as that call center. We do intake screening. We are the InConnect Alliance participants under that state branding. We do in-home and telephonic options counseling and assessment of need, care plan development, Medicaid application assistance. We have caregiver supports. We do care management and nutrition programming through congregate meal programs and home delivered meal programs. Our primary revenue sources, while Older Americans Act is the foundational funding, when you look at the pie chart of AAA revenue these days, it's Medicaid care management revenue. We also receive a state appropriation called Choice, which I kind of call waiver light. You don't have to be as sick or poor to access most of the same kinds of services you can access through a Medicaid home and community-based service waiver. We also do private healthcare contracting with private healthcare payers, whether those be healthcare systems or insurers, and of course, private fundraising, which we've discussed, as well as several AAAs also can do these services on a private pay basis. And so our job when an individual approaches us is to mix and match these funding sources based on consumer eligibility. I mentioned there's some variety among the area agencies on aging. Several of them, about half of them, are transportation providers. Either they're the full-on rural transportation provider, providing specialized transportation services for older adults and people with disabilities. Several of them are housing developers, affordable housing. 5 of them are community action program agencies. Kind of goes around the wheel there in terms of all the kinds of things we may be involved with as multi-service agencies in communities. So that gives you just a tiny bit of an overview of how AAAs show up in communities and with the state. And so I want to talk with you about how we show up in behavioral health. So the main way that we connect with those issues is in the care management programs we offer for home and community-based services. As I mentioned, we're doing in-home assessments on individuals, in-depth assessments that address people's health-related social needs. And as part of those assessments, the validated NRRAI assessment, we are looking at things like cognition. We're looking at things like mood and behavioral issues. We're looking at things, psychosocial issues. We are also documenting medications. So we are able to determine if there are mental and behavioral health related medications in the home the person may be prescribed. We are also documenting any clinical diagnoses they may have, which can include a mental health diagnosis. And so a lot of times we're walking into situations in which an individual has anxiety, depression, substance abuse disorder, kind of grief, loss. Goodness, not too exciting. grief and loss and social isolation. We also have triple A's that are involved in the, can someone fix this for me? So I'm not trying to talk and do this at the same time. Batteries just. We are also involved in some triple A's are actual providing guardianship for older adults, which can include persons with severe mental illness. And through either the, thank you, through either the funding that the state provides through the Division of Aging, yep, thank you, or through the state's VASIA program run through the Indiana State Supreme Court. So that's how we're interacting with people regularly with severe mental illness. As a result of that, and Kate's going to talk about this a little more, so I don't want to steal too much of her thunder, but we've been able to enter into a partnership with the Division of Mental Health and Behavioral Health around providing some specialized grants to AAAs whose purposes are to increase referral and connection primarily for mental health clinical services, as well as enhanced education and training for persons interacting with older adults and behavioral health. And so about half of our Indiana AAAs are grantees, and Kate will share more on this, but some of our short-term wins include establishing enhanced staff training and protocols at a AAA for how we handle issues related to behavioral and mental health. We have AAAs that, based on the data in their systems, have been doing some more targeted outreach to consumers that have mental health issues showing up in their assessments and in their diagnoses. And as a result, we are receiving increased referrals for behavioral health services. These grants just kind of started, 6-9 months ago. So it's an ongoing process, and we'll look forward to seeing some great outcomes as these grants go forward. We also were extensively involved in mitigating social isolation. And so we have a decades-long history of encouraging communication or community engagement through AAA programming, such as congregate meal programming, evidence-based healthy aging programs where we're connecting people in a classroom setting, teaching them how to better manage their health. Retired senior volunteer programs, or other kinds of programs that may be available at that area agency on aging to keep people engaged in the community. These services were really stressed during the pandemic. So we were on the front lines with FSSA in trying to help older adults remain safe at home during the pandemic, which we know increased social isolation. And so many AAAs even added additional interventions, friendly calling programs. They may have recalibrated their congregate meal program to ensure people were still being engaged in some way, and that social isolation was being mitigated. Every day we're getting emails about some new iPad-based innovation on people being able to access online networks of older adult programming and that kind of thing. So we also partner with Engaged, the National Resource Center for Engaging Older Adults, whose purpose is to mitigate social isolation and activate that kind of community engagement. And it's administered by U.S. Aging, which is the National Trade Association for the Area Agencies on Aging, under a contract with the Administration for Community Living. We've talked about support for caregivers, and Older Americans Act funding includes caregiver respite, includes caregiver support groups, caregiver education and training. In addition to Older Americans Act funding, we have more intensive caregiver support services that are available through Medicaid waiver programs that include structured family caregiving and health coaching and goal attainment. We also have, in addition to those waiver programs, a separate initiative involving 10 AAAs around dementia caregiver coaching, stress release, caregiver assessment, and stress reduction, which is showing fantastic results. And we are also really excited about the multi-sector plan on aging, which will allow us to address issues for caregivers outside of FSSA. We talked about the economic impact related to caregivers. And for that kind of stuff, that's beyond FSSA, right? That's Department of Workforce Development. That is Department of Commerce. That's the Indiana Economic Development Corporation. So, we're really looking for ways that we can engage more persons around and more industries and networks around support of caregivers. We mitigate barriers to clinical services. We can arrange for transportation. We can help with telehealth navigation for people to access mental health services. The ongoing support for health-related social needs is another area we always show up in, which of course contributes that stability, helps support mental health. And we've really tried to show leadership in this state. We had a ongoing leadership for a number of years around the Indiana Mental Health and Aging Coalition, which kind of went by the wayside, but we're hoping this kind of attention will bring back that ongoing attention. So let me talk a little bit about, based on that, what some of our priorities are for this population. First of all, it's housing. Indiana's entire long-term services and support strategy is vested in people being able to remain in their own homes and communities. And you have to have a home. You have to have an affordable, safe, accessible home to do that. And so we are constantly working with the Indiana Housing and Community Development Authority. We've got legislation moving through the General Assembly right now that would actually add housing expertise to the Indiana Commission on Aging and the Indiana Choice Board. We're going to try to get summer study done on Medicaid, how Medicaid can expand supportive housing. So again, we know that's an issue for persons with serious mental illness as well. And so that's one real area of kind of that cross collaboration. We've talked about supportive caregivers, and Ellen in her earlier remarks highlighted, there you are, some states that have programs that are looking at things like long-term care savings programs, looking at retirement savings programs that are state-sponsored, that are offering dependent care tax credits, that offer paid family leave so that we can continue to support those caregivers. And those are some of the things we want to hook on to in the multi-sector plan on aging. We want to continue to be able to mitigate social isolation, and some of those mental health grants are going to help with that. In some of the particular interventions around warm lines or kind of continued outreach with friendly kind of access. But there's lots of other ways we can continue to do that. We want to continue to be able to bust those barriers and support health-related social needs, particularly transportation. Another area that popped up was telehealth access and navigation support. And so it's so fantastic that access to telehealth has really expanded what can be provided in mental health support. But we've got people who can't navigate telehealth. And so we need to be able to support that telehealth access, not just in terms of being able to work with an iPhone or a smartphone or a tablet, but also broadband. We show up in broadband hearings saying, this is why we need broadband, because older adults need broadband. We also want to emphasize the need for support for training for the direct support professionals that are going into people's houses and providing their attendant care services, that are kind of doing those, providing the handy chore, the handy chore and homemaking services, other folks that are interacting on a regular basis with people in their homes, so that they know what to do when they start seeing mental and behavioral health issues. So how do they handle a crisis situation that's breaking out, or what referral do they need to make if they're starting to see some emerging issues? As part of FSSA is involved with a training plan for these direct support professionals. And we think it's critically important that that mental health training and behavioral health training be in that curriculum. And finally, we are actively supporting integration with paramedicine and community, the community paramedicine and mobile integrated health. We see this as a fantastic referral source to the Area Agency on Aging system for that long-term care management and access to Medicaid and other kinds of things that will promote that community longevity. Community paramedicine and mobile integrated health can get at populations we don't normally see, who don't know we exist, or maybe just at a higher income level. And, you know, they've called the AAA, they can't get care managed services because they make too much money. But maybe there's something that can happen in terms of clinical chronic disease management, somebody coming into the home to follow up on blood pressure or sugar testing, those kinds of things, A1C on a regular basis through the mobile integrated health initiatives. So we really see it as a way to continue to support older adults staying in their homes. Okay, so those are, I went through really quick those key priorities, but we realize that those are going to require investment. And to Jay's point about we need to be realistic, but I understand that, but the AAA's primary role is advocacy. And so we need everybody's support in helping legislators understand and kind of pull their heads out of the sand about Medicaid and the kind of investment Medicaid's going to need for the next several decades around long-term services and supports because of the baby boom generation moving through the system. And so this does include recommendations about ongoing funding support. But one of the sustainability things doesn't necessarily require a lot of funding. And we think there needs to be continued attention for behavioral health and aging and ongoing focus beyond just this meeting of the Behavioral Health Commission. And so we are recommending some kind of stakeholder body that could maybe be tied to particular initiatives to keep raising this issue up. You know, we'd be a big advocate for additional Medicaid waiver services, standalone waiver services for severe mental illness. You know, we'd love to see Medicaid explore chronic disease self-management for behavioral and mental health diagnoses as a covered service. We have existing Medicaid waivers that could be expanded to enhance the mental health services that might be provided there, or some of the things that support mental health access. In addition, Administration for Community Living annually has chronic disease self-management grants for infrastructure and capacity building. And those require looking at evidence-based healthy aging prevention and healthy aging wellness programs. And I haven't gone through the laundry list because that list grows every day, but I'm certain there are mental health ones that are addressing older adult mental health. So we would love to work in partnership with the state and applying for one of those grants. And finally, because of these short-term successes we're seeing in the grants that we've got from the Mental Health Division right now, we'd like to see that as an ongoing state appropriation. So we'd be willing to advocate for that as well, so that we can fund those that targeted focus on mental health within the AAA network beyond just the general care management that we do. Okay, so that is the end of my presentation. I hope I hit my 15-minute mark. But I'd be happy to have any questions or discussion with you. Thank you.
All right. Thank you, Kristen. So we're going to move right ahead. Thank you so much for your presentation. Before we turn it over to Kate and Gina to kind of finish up, I wanted to make sure that anybody from the public that is attending here did not have a comment. Okay, and for folks that are watching online, I believe it's been the instructions for an email comment have been put in the chat. So. All right, kind of finish up here. We have a couple people. We have Kate Hager from DMHA, as well as Gina Woodward. So Gina, when you stand up, Gina is our Behavioral Health Workforce Director. And so throughout the commission meetings, we're going to have what we call Gina's Workforce Corner, where because we know workforce is sort of a common thread throughout this whole conversation. We've already heard it in several different iterations today. And so I think Kate's going to just present a little bit of data, and then Gina's going to do a really quick, just kind of more of a preview for what's to come, I think, if that's okay, on workforce, and then we'll get everybody out of here. So Kate, take it away. Thank you.
Okay, can you all hear me? Okay, I tend to mumble, so I apologize in advance. Please just like raise your hand and tell me to speak up. I am speaking today. Andrew is over there. He's been an active participant in this process, but we'll be talking, or at least I'll be talking today about aging and behavioral health. Just a quick overview from a state perspective. So we have an interagency collaboration that we've been working on, I'd say, for the past little over a year. Just after I got hired, Division of Aging was ready and raring to talk, so I was open to talk to them. I am the Older Persons Initiatives and Support and Employment Director at the Division of Mental Health and Addiction. But we'll also talk briefly about some of the Division of Mental Health and Addiction oversight. I'll shine a light on the Area Agencies on Aging grant, topics for further consideration in workforce. Gee, thank you. All right, so like I said, we've been doing this, or at least talking to each other for about the past year and a half. Our goals are to align aging and behavioral health services. Historically, federally, locally, top down, we've seen behavioral health and physical health be treated separately as two unique things. We know now, and we know better now, that this is not the case. So one of the ways that we're starting to look at behavioral health and aging is, first and foremost, even looking at what data we have available in this state. So we've been trying to tie DMHA data with the Division of Aging data, and this can help inform policy, but also importantly, this can provide like an environmental scan of what's happening in Indiana, because we don't have the best view of what's going on. We are also working on initiatives together. As Ellen and multiple other speakers have commented before, I think just about everybody have mentioned that behavioral health and aging work hand in hand. They intersect. You really don't have one without the other, and one impacts the other. So a little bit about what we're seeing in the data. Just a quick overview. These are Medicaid recipients. We do not have Medicare data yet. That's an area that we really need to broaden and get a better idea of, but it's an ongoing process to get Medicare data. So this is the Medicaid population, and this is the age group 55 and up. I'm going to throw out different age ranges, and it's going to be a little confusing, and I apologize. But 55 and up is the program for all-inclusive elderly. That starts at 55. So that's what we started at this age. The light areas that you see on the map, that is about 3 to 6% of the Medicaid population has a behavioral health diagnosis. That's not necessarily serious mental illness as defined by the Centers for Medicaid Services, but it is a behavioral health diagnosis, and that includes substance use disorder. The dark green areas on the map are about 8 to 10% of the Medicaid population. These are the top diagnoses that you see. These shouldn't be too surprising based off of previous speakers. Depression and anxiety come in at the top. You see substance use disorder down in third. But I think what's really important to highlight is that schizophrenia, bipolar, and trauma and other stressor related disorders all are about even, right at those bars right there. And we know in particular with schizophrenia and bipolar disorders, there are significant physical health comorbidities and significant risk of dementia diagnosis later on. Personality disorders are at about 100,000, so they're just kind of right there. But I wanted to pull that data just to take a look at those, because we do know those can tend to be tied to social isolation. As you can see, the health impacts are considerable. What we did is we took individuals with behavioral health diagnoses and we looked at what kind of physical health diagnoses that they have. From these beneficiaries, we can see some pretty common physical health diagnoses that includes high blood pressure, respiratory disease, diabetes, heart disease, infections, and nutritional deficiencies. These are all significant. These all increase risk of medical complications, poor physical health outcomes, and death. So these are really important to address, not just from a behavioral health perspective, but also from an aging and physical health perspective as well. So what can we do about it now? We have a couple options. More importantly is we have the Indiana code. Underneath Division of Mental Health and Addictions Code, we have the opportunity to research the entire problem of behavioral health. And I am not a lawyer, Jay can correct me on this, but I believe that includes aging and behavioral health services. I think this is a really novel code that we can leverage to research the intersection of aging and behavioral health. And we can do this through continued data integration between our two agencies. And this research can inform policy decisions and recommendations. We also have our Indiana Administrative Code. This one is specific to our community mental health centers, and it is a great opportunity for our two providers to coordinate and collaborate together. This has been in existence for a while by my predecessor. So I wanted to sort of leverage that code by working with the area agencies on aging, and we had the opportunity to utilize some block grant funding. We put out a competitive award last year. 7 of the area agencies on aging were awarded, and we cover most of the state, both rural, urban, suburban, you name it. They began in July of 2023. It will last 2 years, so they'll go until June 2025. There's about 4 million in this in the grant funding, and to be eligible for services, their client or their area agency on aging care recipient needs to be 60 and older. It's not 55 and older, it's 60 and older to align with the Pathways program. And they also need to have a serious mental illness. This is defined by SAMHSA as having a diagnosed behavioral health condition that impacts their functional capacities and impairs them. And as Kristen just mentioned, every area agency on aging is different. So every grantee is a little bit different, but they all have core services. A big component of this is identifying their members with behavioral health needs, just even identifying them, bringing it to the light. And another component is connecting with behavioral health services in their area. And another aspect of this that I didn't think about, but a lot of them are even exploring what's available in our area. Let's find out who's available, who provides services, let's find it. And then connecting and collaborating with other providers. This is a key component and one that we're particularly interested in. We should not exist in silos. We don't do care in silos. Let's break out of that and work together on collaborating and ensuring that different treatment plans, different goals are aligned with one another, and that we're all aware of what's going on with the person and really truly be a person-centered system. All of them are also working on increasing their knowledge for staff. They've been providing various types of training for them. Talking about behavioral health is a big first step. And all of them are also reporting and identifying opportunities and gaps that they're seeing within their areas. Some of the unique services, Kristen mentioned this, are warm lines. I don't think she explicitly said warm lines, but warm lines are a great place to call. If it's not a crisis, you would like someone to talk to. It's a way to get connected to services, and it might be an opportunity for folks that might be unwilling to connect with behavioral health providers. It might be a more agreeable and amenable phone call than calling someone else that is explicitly a behavioral health provider with this age group. We also have community health workers, which are fantastic at connecting and referring to services. Some are hiring their own behavioral health staff. Others are developing just best practices. What do we do when you've historically treated physical health conditions and your funding has been tied to a medical condition? The knowledge base for treating behavioral health may be an area where it needs to be improved. Some are also doing behavioral health, like developing a behavioral health assessment tool to help identify and connect members to services. This is sort of just a general brief visualization for those that are more visual learners. But you have the client that's receiving services from the AAA, and the AAA acts as kind of a spoken wheel model. So they're connecting and regularly talking to us at the state, I should say. And they're also coordinating services for their physical health, their and their other service care providers. So the new one that's been added on explicitly and really tied, and one that they're all working on diligently, is working with behavioral health providers in their area and connecting and bridging those gaps. And just topics for further consideration is researching older adults and behavioral health. We can do this underneath existing code. I think it's a simple topic that can be brought to the forefront. We also need to continue to coordinate behavioral health and physical health services. We need to integrate, not just below and site providers need to integrate, but we at the state also need to continue to integrate and collaborate and talk with each other. We can also explore aging-friendly communities for those who need both physical and behavioral health services. And the multi-sector plan on aging has been mentioned several times. So with that, I will turn it over to Gina.
Hi, everyone. I appreciate the opportunity to just kind of close up the conversation for today. I'm here to celebrate the fact that this gets to be an ongoing conversation for us. And I think that's an amazing thing. I think everyone in the room and probably everyone listening would agree that that's a great place for us to start today. For me, bringing us back to the work that the commission or that the Behavioral Health Commission did last year is important because we had some specific goals related to workforce that I think continue to resonate with this conversation. So I wanted to share with you one of the statements that was made related to workforce and the importance of focus in this area as we improve care quality and access as a state. The lack of adequate workforce is the single biggest obstacle to implementing many of the Commission's recommendations. And unfortunately, workforce issues don't lend to easy and short-term solutions. So it's important for us to just bring this back. And I don't want to end on a negative. I'm going to end on a positive with the fact that we're still having conversation about how to approach this from a systems level. And so I want to kind of, from DMHA's perspective, we are trying to emphasize the importance of recruitment, training, and retention when we look at workforce. And I think that's no different from many of the conversations that came up today as a part of the focus on our older populations. And so some of the things that I feel like we can circle back to in workforce focus include the importance to improve access to care. And access to care and quality of care often leans in on workforce strategy. So we know from the presentation today that Indiana we're affected by workforce shortage, as many other states in the country are, but the majority of the counties in our state do have shortages in the area of workforce for mental health. And so being able to improve access and ensure high quality care means that we have to look at recruiting additional folks into our field on a regular basis to grow our ability to build capacity. So that as we continue to strategize and think about recommendations for future, thinking about how workforce and access intersect is very, very important. Another thing that came up today in a number of ways is the importance for us to focus on treatment extenders as a way to grow capacity, as a way to improve quality of care, and as a way to improve the specificity of our range. So when we're talking about older adults specifically, that training piece comes into play, as well as folks with lived experiences that they bring to the table for workforce. A third topic that came up, I think that we want to mention and raise up is the idea of addressing administrative barrier. We know that for workforce, that can be a huge issue, whether it's around policy, practice, licensing, training, education, scope of work. All of those things have indications for us that are barriers that are in administrative practice. And so as you all consider recommendations as a committee, considering that as part of our solution opportunity, I think is highly important. And then finally, as just a summary and a result of all of the amazing people that presented for us today, the idea of innovation I think is one that we really need to lean in on with workforce strategy. If we continue doing this work the way that we always have done, it's going to be barely close to impossible for us to reach that threshold where we're able to embrace our entire community and provide the quality of care at the rate that they need it as we grow as a community. So that's all I wanted to bring up with you all today, is just that concept that this is an ongoing need for us to continue when we focus on solutions, to build in the how and how that relates to those individuals providing care. I think it's very, very, I guess, fitting that that is what I can bring to you today when we talk to the population of aging adults, because I do feel like that is one of our areas that needs that special lens, and that's that special training, special care, special individuals coming to the field to provide the services. And so we'll leave you with that, as Jay mentioned, the teaser to more things to come, keeping this as a priority and hearing more about how we can build on strategy and systemic approaches to workforce. Thanks.
All right. Thank you, Gina. Well done. You'll be hearing a lot more from Gina as the commission's work continues. So with that, we have about 5 minutes left and we're going to end on time. Are there any further comments from commission members?
So just a comment, Jay, regarding, first of all, I think the intentional focus of DMHA to bring on a workforce individual such as Gina is probably one of the best things you did in your leadership. So thank you for that. And I'm very grateful for the work Gina's done. And then the other piece of this that I don't think we've addressed entirely with some of the speakers when it comes to the aging population that I do worry about is our aging population within our state hospital system and the group homes and the means to be able to meet those needs to get people out of state hospitals. So assisted living and nursing homes will exclude folks who have psychiatric diagnoses primarily or aggression. And so as we're trying to get people back into home, there is a step to get there, especially for those with SMI. And so I just think we need to include some sort of solutions in that of this report long-term, because staying in our state hospital is not the solution for either the state or those we serve.
Absolutely. Thank you.
Yeah, I just wanted to thank everybody who came here today to speak and kind of lend their expertise, as well as the members of this commission. Obviously, I think we could probably speak for even longer about this population. And I'm not just saying that because that's who I'm representing, but it's also because of the unique nature of what the older population is dealing with in this space and just in general. So I look forward to kind of continuing discussion. I know that today was the focus on older adults, but I also know that it's going to be a continuing discussion going forward, and just looking forward to working with all of you so that we can ensure that this population kind of gets that focus that may have been lacking in other avenues and other places.
All right. Well, I think it's fitting that Jason gets the last word here. Logistically, I think we're going to take this all in, process it. We have people taking notes. We're going to send out some minutes. And then we're going to do this again for a couple of different population groups and then kind of absorb it all. And then we'll have a meeting about the report, which I think where we'll put kind of all these things together and see if we can organize them in a way that makes sense. Because ultimately, I think we learned last time, and I think it was proven true, that the presentation of our recommendations is as important as the actual recommendations themselves. So with that, thank you so much to UIndy and Ellen and everybody for hosting us. Thank you again to Kate for planning. She's mortified right now. The spotlight's off you now. And thank you to our speakers, and we are adjourned.